Ma'am, shall we start, ma'am?
Okay.
Good afternoon, one and all gathered here. I welcome respected Chief Guest, Dr. Kaushik Ganguly, Honorable Professor Dr. Rema Chandra Mohan, President, Tamil Nadu NNF, Dr. Lakshmi, Secretary, Tamil Nadu NNF, executive members, distinguished resource faculty, and beloved participants from various institutions. On behalf of Tamil Nadu NNF and Dr. Mehta's Specialty Hospital, we are greatly honored and pleased to welcome you all for this webinar on neonatal respiratory supportive care. Now I call upon Dr. Lakshmi to introduce this webinar. Welcome, ma'am. Yeah, ma'am.
Dr. Lakshmi, you are on mute.
Okay, அவ்வளவுதான். அப்படியே பாருங்க ஒரே
Dr. Lakshmi, you are on mute.
நீங்க அட்டெண்ட் பண்ணதான் சர்டிபிகேட். Good afternoon, Mr. Kaushik. Thank you for joining us today.
Good afternoon, ma'am.
Second webinar after the COVID webinar which we did.
Already
Joining hands with NNF, ACOM and UNICEF, we are doing a great job together, and I hope that we do more good activities beneficial to the medical as well as the public fraternity. I would like to say a few words of introduction about, please allow me. Mr. Kaushik Ganguly is a social policy specialist in child survival, and he's been with UNICEF, autonomous with the expertise in health and nutrition financing, public finance, climate change, and research capacity building in developing and less developed countries. In more than 14 years of experience he has in different roles of social science research, hands-on research in the area of assessing the health system, health financing, tourism, and public expenditure accountability. Cross-country collaborative research projects in Latin America, Central, Eastern Europe, and Southeast Asia. It's a great privilege and honor for us to have you, sir, for this very important webinar on neonatal respiratory care, especially for the nurses, because they are going to be the pillars who are at the bedside, and they are the one who are giving us a very good outcome. Once again, UNICEF and Mr. Kaushik for joining this program. I would like you to say a few words and make this webinar.
Thank you, ma'am, for the warm welcome and the invite and the introduction. This has been a fantastic year where NNF, ECOM Foundation, and UNICEF throughout during the pandemic, we had very significant and substantial collaborations on a number of training and webinars that we organized together with your leadership and NNF's leadership and ECOM's contribution. I am sincerely thankful for this collaboration to come forward again in this year to forge ahead on the important issues of neonatal survivability, important quality of care interventions, training and webinars on important quality of care interventions to improve services and quality of care in neonatal units across hospitals in Tamil Nadu. We know that recent Lancet study published by the Global Burden of Disease, actually at the state level, says in Tamil Nadu already we have achieved, although we have achieved the SDGs in terms of neonatal mortality rates, but 70% of the infant deaths still happening are due to preterm birth complications and associated factors, which can be prevented by improved quality of care at the facility and at the community level. So this is an important step that under the leadership of NNF and collaborative efforts from ECOM Foundation, that we continue to engage in this area and build capacity of our stakeholders through your leadership. And with that words, I will hand the floor back to you, ma'am, to start the proceedings. And thank you once again for your.
So you can go ahead. I have muted them.
Over to Payani sister to start the webinar and introduce speakers.
Ma'am, Dr. Rema, ma'am. Is there? Dr. Rema? Ma'am, you want to take first class, ma'am? Dr. Rema will join later.
Okay. No problem. I'll do it.
I'm very great privilege to welcome Dr. Lakshmi, Secretary, Tamil Nadu NNF. She has completed her MBBS in Madras Medical College. She is with 20 years of experience in neonatal intensive care. She has done her DNB neonatology in Kanchi Kamakodi Child Trust Hospital. She also serves as the academic coordinator for all DNB students and fellows for the past 10 years. Ma'am has also published many articles, paper and poster presentation. She is a life member of NNF and currently she is working as a consultant neonatology HOD at Dr. Mehta's hospital. Over to you, ma'am.
Screen sharing, can you give me screen sharing? Because it is telling that you have to give me screen sharing. Okay, now? Can you see my screen?
Yes, ma'am.
Can you see it?
Yes, ma'am.
Good morning, all of you. Today I am going to talk about how the nurses should take care of a ventilator newborn. You people are more than us, you're all experts in this. But methodically, we'll be able to do so many things without much panic. So let me take this through to you. Nursing care is more important, the most important for a neonatal ventilator. So in this webinar, kindly others unmute your thing. Ruth, somebody. Yeah, please. Thank you. Ruth Ponmalai, please mute. So we have the following agenda for the talk on introduction on respiratory care, how to assess a baby on a ventilator, and the other accessory care to respiratory care, which are important from the nursing point of view, like thermoregulation, skin care, development care, and family supportive care. Nursing a baby who's on a ventilator is very, very challenging, we all know. And it is a multidisciplinary care which involves not only the physicians and nurses, but also the respiratory therapists. Nurses, they are the vital link between the patient and the disciplinary team. And you will have to have a very good knowledge and skill in interpreting the physiological, the behavioral, the technological information with hourly assessment of the baby and the care. And they also help to determine the infant's response to the treatment we are giving. So whatever be the mode of ventilation, be it invasive or a non-invasive, the nursing principles from the nurse's point of view, we should know the most appropriate device, the technique and the strategy. The basic aim of ventilation is to provide adequate pulmonary gas exchange. At the same time, minimize the risk of lung injury, and at the same time, recognize and prevent ventilation associated infection. All this with reduced work of breathing, and the baby should be comfortable. Everything should be achieved resulting in appropriate oxygenation and ventilation. So the principles of newborn ventilation, then the newborn dimension, how is it different? What are the equipment, manpower needed? We'll see slow one by one. Most of the things you all know very well. Nurses who've been working in a neonatal unit and taking care of ventilated baby. But there are certain things which are good to know, and you can learn a lot from this. So what is ventilation? It is a process of gas exchange, transfer of oxygen from the air, from the ventilator to the airway to the blood, and the carbon dioxide from the blood to the atmospheric air. And okay. The product of frequency and tidal volume, which is the minute ventilation. There are certain things in the ventilator which will tell us. One is the frequency, at what rate the baby is breathing. Two is the tidal volume. The pressure you give, how much tidal volume comes. So when the lung takes over, the lungs ventilation is taken over by the ventilator. The lungs function is done by the ventilator, and it tries to give you oxygen and it removes carbon dioxide. So certain settings in the ventilation which will help doing this is the oxygen concentration, FiO2 we set, the PIP and the PEP we set, which determines the mean airway pressure. So all this ventilator setting will help us to improve the oxygenation and eliminate the carbon dioxide from the system. A newborn is little different when compared to older children and adult, because the chest wall is very, very, very compliant, and the lung is not so compliant because of various disease like RDS, meconium aspiration, pneumonia, pulmonary edema. And the diaphragm is also very weak, and the diaphragm contractility may also be not very good because of poor lung compliance. And the lung is also very, very fragile, and they can get easily injured by our modes of ventilation. As we all know, this is a ventilator which we set. We put the tubings. The tubings are connected from the ventilator inspiratory limb to the humidifier, and then the inspiratory limb. Then it goes to the baby through the endotracheal tube. I put a test lung here. Then once your lung gets inflated, the air will come out through the expiratory limb. And there is a flow sensor. There is a thermal sensor to monitor the temperature from the humidifier. The humidifier should be connected to the inspiratory limb. That much you have to do. Many people, many hospitals will have respiratory therapists and manifold room people who will come and set the ventilator. But in our hospital, our nurses do the ventilator setting up. Yeah, we need lot of manpower when it comes to ventilation. Why have I put 60% here? One baby on a ventilator takes off 60% of the time of a nurse. That means you know how much work a nurse has to do as we put a baby on a ventilator and walk away. So ideally a baby on a ventilator needs 1:1 nurse, but sometimes we are forced to have one nurse taking care of 2 babies on a ventilator. So this nurse must be very adept with her skills, and she should have adequate knowledge of ventilation, and she must have had a regular training and attending webinars like this, constantly updating her knowledge. And yes, she should practice strict asepsis. So the components of the respiratory care or setting up of a ventilator, all the ventilator monitoring equipments, the oxygen delivery system, and the patient oxygenation status. Special concerns are their main concerns are the securing the ET tube, maintaining the airway patency so that it won't get blocked. Then we have our monitoring system ready. And suppose there is something, we should always have an alternate ventilator setup ready. So first, when we tell sister, we have to ventilate this baby, when we tell them, they quickly assemble the entire kit ready, which includes the appropriate size ET tubes, laryngoscope blades with tight bulbs, additional battery, then a ventilator bag with reservoir connected to an oxygen source to hand ventilate once we secure. You may even keep a neopuff or a T-piece ventilator. We need mask of appropriate size. Sometimes when the ET tube is not being secured, we may have to hand ventilate in between and oxygenate up to 100% before the next attempt is made. One person cannot keep on trying to intubate when the baby is desaturating, right? Suction apparatus, yes. When the doctor puts in a laryngoscope, he just gives a hand suction apparatus and the nurse gives the appropriate size suction tube, because only smaller suction tubes, 5 and 6, go through the endotracheal tube. Whereas when you want to suction the oral and nasal cavity, clear the secretion, you may need a bigger suction catheters of 10, 12. And if so, meconium, it may even be 12, 14. So the suction apparatus should be well assembled. The pressure, manometric pressure in the suction apparatus should be 100. Time and again, when we go to the labor room, they may even give us a suction apparatus used during the labor and all that. Where very high pressures are used, which can injure the mucosa and cause undue damage. So suction apparatus, the manometric pressure should be monitored well below or equal. And of course, once tubed, tape for fixation, scissors, everything should be kept ready, and the functioning ventilator should also be ready. So yes, this is the equipment check. All the larynx blades, the suction catheters, the ventilator tubing, ambu bags, the plaster, everything. Then once we decide to ventilate, okay, we should know what is the indication for ventilation in the newborn. That is, baby has got respiratory distress, high FaO2 requirement, maybe even after giving CPAP or HFNC, or for a surfactant delivery. As I told you, the PO2. Shmina, can you please mute? Sandhya, mute. PO2 and a high PCO2 is also an indication for ventilation. And for RDS, you will be ventilating with oxygen requirements. So these are all some of the indications where we put a Shimna, can you please mute? Mute.
I think the administrator, whoever is controlling, can mute everybody.
Sister?
Only sister, just mute everybody who's attending the conversation. No?
There must be at least one spare ventilator which should be ready, because sometimes we have 5 ventilators and all the 5 ventilators are, and the 6th baby comes running around. The circuit and how to set the ventilator should also be checked by us. Very important is the inspiratory limb should be connected to the humidifier, and the humidifier be connected to the inspiratory limb and then to the endotracheal tube. That's very, very important. The thermal probe of the humidifier should also be connected. And the inspiratory and the expiratory limb, as I showed in the picture, are connected to the ventilator. If you have a flow sensor ventilator, it should also be connected so that your tidal volume should be monitored. And a humidifier, please make sure adequate water level and the temperature are there in the humidifier. So it is our duty to get the right connection, the air and oxygen, and the same thing connected to the rear of the ventilator. And this is the tubing, the blue inspiratory limb and the white expiratory limb. And yes, the humidifier and the temperature set with the water level. So this right connection should be taken care. I'm not sure this video is opening here. No. So once the circuit is set up, the ventilator is switched on, we'll note the weight of the baby, because most of the time the gestational age and the weight of the baby help us to set and what is the problem for which we are ventilation. You should also know what are the basic modes of ventilation. Most of the time the resident will be setting up all the ventilator settings like the mode, the flow, the PIP, the PEEP, everything based on the weight, the gestational age and the disease. Always make sure you connect the ventilator to a test lung and check whether the ventilator is functioning before you connect it to the baby. So the next important aspect I want to dwell a little bit on is humidification. All of us will be using a humidifier and the temperature set. Why should we use a humidifier? Normally, our nasopharynx, oropharynx and upper airway, they act as excellent humidifier for us. They humidify and moisturize the air we breathe, which goes into the lung, and also they come out very well. When we do an endotracheal tube, we bypass all this. The air, it enters through the endotracheal tube to the mouth, through the nose, into the lung directly. They don't have a chance to get humidified or warmed up. When you don't humidify and warm up, it causes a lot of problems to the lung, to the baby. It dries up the secretion. It allows the lungs to collapse or the alveoli to collapse. It gets infected. As a result, your lung will become poor compliant. It will not ventilate well and you will get into hypoxemia and hyperoxemia. So with all the settings rightly made, always make sure you test it with a test lung. This is a beautiful distilled water saline going into the humidifier. The temperature is set, the inspiratory limb, everything is now. Now you are ready to connect it to the baby. So just a little bit you should know about all these modes of ventilation. What are the names? As you keep attending, you can always enhance your knowledge. And this is what is the once we connected, you also keep looking at the monitor. The flow, whether we have done it right, the inspirate PIP, the PEEP, the frequency, how many breaths per minute, the oxygen concentration, what is the I time. Sometimes when my nurse, I'm very happy and privileged to tell this, when our nurses went for their NNF exit exam, the doctor from Pune called me and told me that your nurse is equal to one neonatal fellow. Like that good knowledge she has on everything. So you can tell a new fellow, sir, this is what it has to be said. And that is what is nurses empowerment. And we want to go ahead. The second is, once you've set up everything, you have to assist in intubation. It is a very major procedure. One thing wrong is there is no glove in this hand and the doctor is wearing a watch. As a nurse, you should not allow them to do that. You have to make them wear their gloves, mask under good sterile condition. You should do it. You should also make sure they make their attempts within 20 to 30 seconds. That is your responsibility. They cannot keep on attempting. And if more than 1 or 2 attempts are needed, you have to call for help. And the third important thing is you have to pre-oxygenate. You monitor the baby while intubation attempts are made. If the baby is becoming hypoxic, we have to abort the attempt. We have to give a positive pressure ventilation, improve the FA oxygen saturation to around 95, and then take the attempt. So you have to choose the right size of the tube, the endotracheal tube, the right size of the tube and the right position of the tube, where to fix the tube. So NNF guidelines are very clear in that less than 1000 kilo, 1000 grams, you use a 2.5, then 3 and 3.5. So the appropriate size of the tube based on the weight of the baby, you have to hand over to the concerned person. And also fixing up the tube, there are which is superior is still not known. Nowadays, nasotracheal length from the nose to the tragus is also being practiced, and add 1 centimeter, or you use 6 centimeter plus the weight of the weight of the baby in kilo, and you add it to 6 centimeter. So the endotracheal tube appropriate sizes should be readily available, and this is the size chart based on the weight of the baby. Then you have to make sure the tube depth is correct. The tip to lip length is perfectly marked on the endotracheal tube. As you put it too deep, you're so scared the tube will come out, you try to put the tube in and in, it will go and get stuck to the right side, and that can cause right main bronchus intubation that produces pneumothorax in the right side, and atelectasis, left lung is not well ventilated. So the right depth of insertion is also your responsibility. Make sure it's fixed at the right time before you secure the plaster. See this? The carina is there, just 1 centimeter above the carina is the right place. Here it has come too deep into the right main bronchus. It is too high, very close to the clavicle, and anytime you may extubate. So you have to put it exactly T2 and below the right side, so that when you pump in air, it goes to the right lung as well as the left lung. See here, it's gone too much in. So the left lung is not at all ventilated, it's collapsed. And imagine if you give surfactant, it will go only to the right lung. So the appropriate size, appropriate tip to lip, the length where to fix, and securing it properly is also here. And another important thing is the correct size, the depth of insertion. Yeah, if the ventilator is on this side, please put the ET tube on that side. Don't allow the ET tube to come across and then fix it to the other side. Sometimes it causes palatal grooving because the ET tube is constantly rubbing the palate. And always keep the tube short. The ventilator, the endotracheal tube from long here to long here, unnecessary dead space. So always 3 centimeter, you cut the tube short and then connect it to the ventilator. The plaster should be very well, neatly secured. I'll show you in the next slide the baby friendly, because when you remove the plaster, the skin should not peel and come off. It's a source of infection, and as well as it damages the skin. And once done and walk away is not enough. Of course, you people are there at the bedside. Frequently, we have to check. So what we always do is we put these baby-friendly tapes initially on the skin so that the skin is not injured. On top, we put the Dynaplast so that it won't hurt the baby's skin in any way. The next is suctioning, which you do repeatedly. Again, I put in bold capital that suctioning is a strict sterile procedure. You have to take precautions, hand sanitize, put a sterile glove, and then do the suctioning. All this are going to be dealt in detail with back. And why we want the ET tube to remain patent, it should not get blocked with secretions. Whenever you do suctioning, quick suctioning, just don't keep on dwelling inside. You're blocking the endotracheal tube, you're interrupting ventilation. And the pressure, as I told you, should not exceed that. And don't use a big suction catheter which will occlude the entire tube, because for a 2.5 size ET tube, you should have smaller suction catheters of 5 size, bigger ones will not go. And again, only if clinical condition warrants, you have to do suction. There is no need for mandatory suction, especially in the first few hours or first day of ventilation. Important thing again I want to tell you is the depth of suction catheter also you should make sure. Don't put the suction catheter beyond the tip of the ET tube into the baby's lung. It will injure the mucosa of the bronchus. So again, to reiterate, suctioning is not compulsory. Universal precaution, indication. Why should you do? Is there blood? Is there fluid? Is there a block? Is there a desaturation? You are doing dope. Choose the right size suction catheter. Check the pressure in the manometer. Check the length of the catheter. Do not advance too deep. Time your suctioning catheter. Quickly come out in 5 to 10 seconds. And in cases, always send the secretions for testing if needed. When do you do suctioning? When you see visible secretions in the endotracheal tube, or somehow the baby is agitated and you think something is not right, and you hear a lot of conduct or kuru 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 no breath sounds on auscultation, or the baby has deteriorated, like dope. I tell you, dope. Whenever a baby deteriorates, then you should always think of dope where was obstruction due to secretion. So the appropriate, see this picture beautifully says, if the ET tube is here, you should not put your suction catheter deep in and injure the mucosa here. So the length, your aim is to remove all the secretions from the ET tube and keep the ET tube patent. So along with the length, you give allowance for the length of the adapter also. Vigorous suctioning is not without complication. That's why we are telling limit your secretion, suctioning, and do only when necessary. Hypoxemia, bradycardia, collapse, mucosal trauma, as I told you, sudden, it is a big bronchus or a sudden, secretion is blocking, and you suddenly remove with suctioning, a gush of air can precipitate pneumothorax. Many a time pneumothorax, when they say, we always say, I was just about to go near the baby, put suctioning. As soon as I put suctioning, suddenly the baby deteriorating. And suctioning is a very irritating stimuli for the baby. That itself will cause agitation and increase the pulmonary pressure, precipitate a bleed, increase your blood pressure. And again, it is a source of introducing infection. There are suctioning where you don't have to open the ET and then do suctioning, inline suctioning. I'm sure Akshit is going to cover. The next is the chest physiotherapy. Chest physiotherapy for just a day or two, ventilator. Sometimes when the baby is stuck on a ventilator for a long time, when secretions are there, we have to do chest PT very gently. Chest physiotherapy means nothing very great. It is to prevent accumulation of secretions, to maintain the airway to patent. Portions of lung which are collapsed are also going to be treated by doing suction. So chest physiotherapy can be by changing the position of the baby should be changed. Sometimes depending on where collapses, sometimes we find a portion of the lung collapsed. So the portion of the lung which is collapsed should be kept dependent, and we may have to change position based on which portion of the lung that is collapsed. Usually the first few hours or first few days it is not required. Changing position is enough. But on babies on long-term ventilator, having lot of secretion, you at least do one per shift. And again, gentle percussion and time it so that you don't spend long time. So it removes secretion, it improves ventilation, oxygenation. Any collapse of the lung will be cleared and pneumonia, so that it prevents a baby getting into pneumonia and all that. You can use a cupped hand, a small nipple of the bottle or a mask to do percussion. You may gently tap like that, or vibration, just keep your finger and vibrate, or gently percuss with your cupped hands. And changing position is very, very important for good chest physiotherapy. Everything is not without complication. Try to avoid physiotherapy in small babies in sick PPHN because it can precipitate bleed and air leak. And all complication even can occur during chest physiotherapy. All the vital signs can change. So be very, very guarded when you do chest physiotherapy. So there are benefits, there are risks, but it is our duty to see the way, the benefit and risk, and then decide which way to go. Then most of the time you are asked to put sedation, analgesia, and give paralysis for drugs. These are all dangerous drugs. Please do not give without doctor's prescription. Ask for a return prescription before you load the drug. Dose, dilution, and duration should be cross-checked by two of you and the doctor. Ask if it is a bolus or an infusion. Always, sometimes, I told you I'm very proud of my nurses who are like fellows. Sometimes they question the drugs. Doctor, the dose is like this, is it right? Yes, you have the power to check and to alert. If you have a doubt, please don't think, oh, why the doctor is giving like this? Usually we don't do like this. Don't keep it to yourself. Raise your doubts, voice your doubts. Make sure you have the right drug, the right dose, the right baby, the right dilution, and always cross-check because these are all dangerous drugs. When do we use? Whenever a baby is agitated and fighting the ventilator, you are not able to get a good saturation. Make sure it is not due to ET displaced, ET blocked, and then go for your sedation. I'm sure all of you must be familiar with all these drugs which we use. I put Vercuronium for muscle paralysis in red. It's a very dangerous drug. Why I tell you, when you deep sedate or give a paralysis, the baby's respiratory drive is lost. The baby is entirely dependent on the ventilator to oxygenate. Please do not leave bedside. Another thing, whenever you paralyze with Vercuronium, your airways will become so relaxed. So the ET tube which was nicely sitting may become very loose and easily displaced. Please be beware when the doctor asks you to paralyze a baby, you will be in trouble. Don't leave the bedside. Keep on checking whether the ET tube is in place and whether baby's chest rise is there with the ventilator. Do not leave bedside. The next important role is during surfactant administration. Again, the nurses have a very crucial, vital role in administering surfactant through the endotracheal tube or a catheter in assisting the doctor during the procedure. You have to ensure asepsis and make sure the doctor is wearing a sterile glove, gown, and all the things which are necessary for surfactant are ready. It's a beautiful picture where we put in a surfactant is directly instilled into the lung by means of surfactant loaded in a syringe. And this surfactant reaches the alveoli and allow the alveoli to expand so that oxygen is good and carbon dioxide is eliminated. And this is the table they set for surfactant. Syringe, appropriate size of the catheter to go inside. So you have to measure the catheter from here to the here and then cut the tube so that it won't go beyond. So all this is being done by our wonderful nurses. And again, monitoring during surfactant installation is very, very important because sudden pushing in surfactant, it's a liquid, it per se may cause obstruction, block and atelectasis. So we may have to ventilate in between to push the surfactant in so that it reaches the alveoli, expands the alveoli and gives a good functional residual capacity. So not only during the procedure you have to monitor, please don't give surfactant and walk away because once the lung improve, we have to quickly wean the FiO2 and the pressure on the ventilator based on the saturation and the chest rise. You have to, unless deemed necessary, baby is crashing, no need to do suctioning. You have to leave the surfactant in the lung for some time. Always don't get very apprehensive. ET bleed can occur following surfactant administration. Two techniques, I'm sure you are very well known about this. Intubate, surfactant, and then extubate to CPAP. Now mechanical ventilation has come down a lot after we started doing this procedure. And the second is minimally invasive surfactant deficiency, surfactant therapy, where a baby is on nasal CPAP without endotracheal tube, you put a catheter and give surfactant. So both of them, most of us are now learning. So yes, so ET tube fixed at the right depth, otherwise your surfactant will go to the right lung. Make sure there are good chest rise after intubating, even before and even after giving surfactant. Once you give surfactant, you beautifully, your saturation starts rising. Please don't leave it on the oxygen like that. Keep bringing your FiO2 to minimum to 25% or room air. And you can also beautifully watch the tidal volume, which is 4 to 6 ml per kilo, improving following post surfactant. Once your tidal volume starts improving, you can wean your pressures. But now we have excellent volume guarantee ventilator where it weans the pressure on its own. So any baby who's on a ventilator, it is the responsibility of not only the doctor, but also the attending nurse to make sure this baby is well, temperature is maintained, color is good, pink, not cyanosed, not pale. The breathing is comfortable, there is not much of retraction, and the baby is also quiet and sleeping. All the pulses, BP, heart rate, capillary refill, I know you're all very good in assessing. This should be assessed time and again. One small thing which is again going to be dealt is your alarm limit. Please don't worry. You worry about hypoxia when the saturation falls below 90. You immediately call us, but also worry about hyperoxia. So we do not want high oxygen concentration 100 all the time. So keep your alarm limits and say no to 100, so that high oxygen per se can damage the lung, can damage the eyes and may not give a good outcome. So evlo low oxygen alerts you, your 100% should also alert you. That is my message from this. So not only that, as I told you, the your monitoring also include the baby, the fighting of the ventilator. Is the baby too alert or is the baby too sedated? How is the respiratory drive? All that is being monitored by you. And also the other profile, no? The blood gas, the laboratory profile, the x-rays, and all the other monitoring for a sick baby is also done by you. I'm sure you will be doing all this in your unit as well. So there are a lot of smart ventilator. No? I always say, no, we should bet on smart nurses more than a smart ventilator. So there are a lot of graphics. Don't go away from the graphics and don't get scared and don't think it is the doctor's job. You come out and start learning because it gives you lot of knowledge. Just looking at one or two picture, you can say whether the baby has got air leak, whether the baby has got secretion, are you over ventilating, are you under ventilating, are you having leaks in the system. All this can be done with your smart ventilator. And other than that, you have other issue. It is just not the ventilator and the tubes. No, you have to look at the baby as a whole. Even a baby is on a ventilator, whether the lines are okay, the central line, the invasive line, the arc line, BP monitoring line, then of course the ET and the other position. And if the baby is on a chest tube, again, you can't move the baby much, you have to have a watch. So all this is beautifully and efficiently managed by our nurse, which includes the vital parameters, the temperature, the heart rate, the blood pressure, and also they periodically disinfect all the things which paraphernalia which are around the baby, so that we don't get into any infection. And this is a nice chart. Nowadays we are paper free and the tabs only we monitor, and we have a nice chart of all the babies on a ventilator, not only the ventilator parameters but also the baby's vital signs. So here comes the big one. What happens? A baby becomes sick on a ventilator or becomes suddenly deteriorating, saturation dropping, color is not good, baby looks pale, there is bradycardia, there is tachycardia, yes. So don't forget dope. First is the tube displacement or disconnection. 2 is obstruction, secretion. 3 is air leaks and pneumothorax because of the ventilator. 4 is the equipment failure. Look if the connections are good, if the power is good. So these 4 important things you should keep in mind whenever a baby is desaturating on a ventilator. So step by step, you inform your physician, you check for the causes yourself, look at the color, look at the monitor, or is it a monitor failure? If you are not comfortable, remove the ventilator, handbag with 100% oxygen, look for chest rise and air entry, whether ET tube is in position, and you can just, without panicking, doing all this. So once a baby is done well on a ventilator, it is time to wean. Again, weaning. Sister, can we wean this baby? Sister, can we take off the ventilator is the first question we ask. So you also, yes ma'am, the baby is being stable in the last 24 hours. I weaned off the inotropes. Oxygen requirement is not much. The baby, I've stopped the sedation, and the hemoglobin is also good, and the baby is also alert. He's able to handle his own secretions. So these are the things we expect when we think of removing the baby from the ventilator, because we don't want the baby to go back again on the ventilator. And also say in the preterm, yes ma'am, we can give a bolus of caffeine so that good respiratory drive. Or if the baby is being on a long time on a ventilator, we may have to give some dexamethasone or steroid to take care of airway edema. And we may have to hold the feeding, next to feed, because we don't want too many things happening around the time of plan the feeding, so that it won't happen at the time of extubation. All this has been beautifully done by our nurses. So it's just not the ventilation. We have to take care of the temperature of the baby all the time. Skin care, there should not be any pressure sore. A developmentally supportive care, we neatly tuck the baby. We keep a nice iPad. We plug their ears so that they don't get into unnecessary noise, light, and irritation around them. We excellently manage the pain they are given. Good pain management, and sometimes non-invasive, we allow the mother to keep the baby in KMC so that they are very comfortable, and sometimes we even allow the family to come in and take part in taking care of the baby. So when one important thing you have to do is handling, frequent handling should not be there. We always write minimal handling, one nice board will be there. So you plan your CBG check, your endotracheal tube suctionings, everything you can cluster your activity together so that when you near the baby, you disturb the baby, you do 5-6 activity and quickly come out and allow the baby to rest and sleep. And please communicate with the family. Be very understanding when the mother, father walks in. Sit with them, handhold with them. They will be worried with lot of tubes. So please spend a little bit of smile from you to the parent is very, very reassuring, and make them sit always. And whenever you're changing from one mode of treatment to another, please make it a point to call them and inform them. All this, you can win their confidence. Sometimes they don't even talk to us, they go talk to the nurse because they are more comfortable with them and they tend to spend more time. So any baby on a ventilator, you should know the indication, you should assess the baby, you should do the necessary preparation, you should set the ventilator, you should assist in intubation, you attach the baby to the ventilator, intense monitoring, supportive care till you wean, and follow-up care of all the babies even after extubation. I think the major role is done by no one else other than our nurses. I'm very proud and happy to have a very wonderful, knowledgeable nursing team in our unit, and a big thanks to them. And I once again take this opportunity to thank the entire nursing department, where they tirelessly they work round the clock in a very good manner, and they have won appreciation from all over the country, from other institutes too. Thank you so much for giving me this opportunity, and I hope I've helped you in this. Thank you. Thank you, Pioneer sister.
Thank you, ma'am. Thank you, ma'am. You have explained well about the invasive ventilation and how to connect the ventilator circuit and suctioning. What are the pressures required for newborn and humidification in detail, ma'am? I'm sure it will be very, very useful for the NICU nurses. So let us move on to the second scientific session. So it's my great pleasure to introduce our second speaker, Professor Rema Chandra Mohan, MD, DCH, PhD, President of Tamil Nadu, NNF. Ma'am has completed her postgraduate diploma in development neurology. And ma'am, she has got 20 years of experience in neonatal and 13 years of experience in head of child development clinic. She is a past president in IAP, and currently ma'am is professor of pediatrics, ICH. And now she's going to deliver a speech about the approach to respiratory distress in neonatality. Welcome, ma'am.
Thank you, Pioneer. Can you hear me?
Yeah, we can hear you, Rama. We can hear you.
Okay, I'm sorry, I had a bit of problem. I should have spoken before Lakshmi. And anyway, she has done a fantastic job, and whatever a nurse needs to know, I think you don't need to refer to any other guide or anything. She's made it very comprehensive for all of you. But my topic is just going to be an overview. It's going to be very brief. I'm just going to talk about, respiratory distress. What are the various causes of respiratory distress in a newborn, and how we are going to approach it. Okay. Okay, so respiratory distress, as we all know, is a very, very common problem in a neonatal nursery, and it's a very challenging problem. It occurs in about 4 to 6% of neonates. I would say it's a commonest cause of admission in a NICU. And it can just pass off mildly, or it can result in severe morbidity and mortality. So one has to keep cognizance of that fact. And we have to identify respiratory distress very early and manage it as promptly as possible so that we get good results. And it is not only the lungs which can cause respiratory distress. There can be problem in any system, as we will see a little later. There can be medical problems causing respiratory distress. It can be a surgical problem. It can occur in preterms. When it occurs in preterms, the cause is different. When it occurs in terms, the cause is different. Sometimes it will just be there for a few hours and it will settle down, and sometimes it will become so bad that it might require ventilation also. So keep on monitoring a child. So don't think that, okay, respiratory distress, madam said term baby, it will settle quickly, I will know. We have to see every mild problem also can become worse. So we have to provide appropriate therapy so that we can save the lives of these babies. Now there are two terms that you have to know. One is tachypnea and the other one is respiratory distress. Tachypnea means only the rate will be high. You supposing if this baby has got fever, you will find that the rate alone will be high. Baby will not have any chest retractions, but the rate will be high. So we have to count the rate. We have to count the rate for 1 full minute. If it is more than 60, why should I count for up to 1 minute? Why can't I count for half a minute and multiply by 2? We know that sometimes these babies can stop breathing for a short time. So that time you will not count the breaths. Okay. So for that reason, see that you count 1 full minute by observing the child without taking off your eyes from the child. Count for 1 full minute. And immediately after a feed, don't count the rate, because the child can have a slightly increase in the respiratory rate. But when you're talking about respiratory distress, it not only means tachypnea, but the chests will retract. It will be going in and coming out, and the child will make a grunting sound like that is a mukkara sound. So he's trying to make his lungs open. He's trying to keep the alveoli patent. And the mari, if he mukkifies only, that lung will be open. But remember that it is a big effort for the child to keep grunting. Slowly the child will go into respiratory failure. Okay. So now the causes, as I told you earlier, majority of the cause of respiratory distress is in the lungs, but even the heart can cause problems in the lung, respiratory distress, or it can be a bleed in the brain, or the baby could have been asphyxiated. That also can cause respiratory distress, or something like a hypoglycemia can cause respiratory distress. Acidosis can cause respiratory distress. All those things. Supposing X-ray is normal and baby is otherwise normal, you may think, what is the cause of respiratory distress? As I told you earlier, hypoglycemia, acidosis and all produce tachypnea, and hyperthermia, hypothermia, even those can cause respiratory distress, but that will be mostly only tachypnea. Now, if we take the causes of respiratory distress, as I told you earlier, it is many causes. Commonest causes will be medical. We'll quickly go through the common causes before we proceed further. So see, as soon as the baby is born, throughout the intrauterine period, the baby has been dependent on the mother's placenta for oxygenation. Once the baby is born, he has to make his own lungs work. Only then the baby will get some oxygen. He cannot be dependent on the mother. So when the fetal circulation changes to neonatal or infant circulation, there'll be small delay in establishment of the respiration of the baby. So that time the baby can have respiratory distress. TTN, all of you would have heard. I'll talk about the remaining conditions. I'll talk to you a little bit in detail. Respiratory distress syndrome, preterm babies, asphyxia, meconium aspiration syndrome, pneumonia, which can be due to aspiration, PPHN, 100 times you would have heard PPHN, pneumothorax. These are some of the medical conditions. Then we have surgical causes also, like diaphragmatic hernia, tracheoesophageal fistula, lobar emphysema, cleft palate, choanal atresia. Then you have some pulmonary anomalous malformations. Those things also can cause pulmonary anomalous malformation. Then history. So very, very important to get a history. From the history itself, to a certain extent, we can come to the diagnosis. So first thing we have to ask is when the distress appeared. Suppose mother says, first 2 days my child was all right. Third day the respiratory distress. So we know we can rule out so many causes. We can rule out RDS. We can rule out TTN. So we think, okay, could be an aspiration. Third day respiratory distress, maybe an aspiration, maybe sepsis, maybe an inborn error of metabolism. Only after the baby keeps on taking feeds, the acidosis will come. So depending on the time, we can tell some to a certain extent the diagnosis. Preterm or term, I told you, if it's preterm, RDS. Term babies, TTN and all is very common. Whether it's a vaginal delivery or cesarean section. If it is vaginal delivery, could be a traumatic delivery, could be asphyxia. Cesarean means it is TTN. Supposing the baby is born through foul smelling liquor or PROM, then we have to think of sepsis, congenital pneumonia. So meconium stain liquor means meconium MAS we can think of. Asphyxia, I told you, hypoxia it can produce. So timing of distress is very important. Find out whether the child is improving or becoming worse. If my child had distress at birth, but now it's improving, we'll think it could be TTN. We'll say, no, it is becoming worse, means most likely to be RDS in a preterm, or in a term baby, it can be an MSL or pneumonia. Supposing it's associated with feed, every time the child takes a feed, the child is having distress. Then we'll have to think in terms of a TEF, choking. So when the child is choking, the child is having respiratory distress. Lethargy with feeds means most of the time it is with respiratory distress means we have to think in terms of an IEM. So now here I've just given you another, just like what I told you previously. From the history itself, you can tell. Preterm means RDS. IUGR baby, kutti papa, respiratory distress. So IUGR means think of polycythemia. This baby will be having lot of RBCs which will block the blood circulation. It can cause respiratory distress. IUGR, maybe there's a congenital heart disease which is causing IUGR. That also can be there. So term cesarean section, I told you TTN. IDM babies, if the baby is born to a mother with diabetes, TTN, congenital heart disease, RDS, polycythemia and all can occur. If the baby is born with prolonged rupture of membranes, I told you congenital pneumonia, the others we have discussed. So choking, when the baby, every time he is feeding, he's choking, means you have to look into the cleft palate, tracheoesophageal fistula or an aspiration. So I'm sure all of you are familiar with the scoring called down score. Why should we do this down score? Supposing I come and tell the baby is having distress, we put the baby on ventilator. Okay, so Lakshmi was telling that we have every right to question the doctor. So the new doctor is coming to your nursery. He's telling this baby is having distress, put the baby on ventilator. But you feel that the baby's distress is very mild. With oxygen, the baby will settle down. So then what can we do? We can score. So I can tell you, sir, this distress is only mild retraction, sir. So the score is only 1, sir. So why should we put, but supposing all these criteria are there, that means the rate is more than 80. There is severe retractions, there is cyanosis, no air entry. So any score which is more than 7, this child should be put on ventilator. So 7 and above. So put the baby on ventilator. This is an objective way. There is no argument. You can write there down score 5. I put the baby on ventilator. Baby's score is now 3 from 5. Baby is improving. So I'm taking out from oxygen. So it is objective. Anyway, okay, your thing goes to court also. They will say, see, this baby was worsening, they put on ventilator. Or baby was improving, they removed from oxygen. So very, very important to do a scoring. Similarly, in a preterm baby, we have something called Silverman-Anderson score. That depending on the retractions, we can score. So there is only upper chest. There's depending upper chest and lower chest. So depending on the grade. Supposing the retractions are very mild, okay? So upper chest only mild retractions, only tachypnea. But here there's a kind of a seesaw movement. Here, like seesaw movement. Okay, so severe retractions, it is involving this xiphoid process also. There is alar nasal flaring. Okay, if all these things are there, then it becomes grade 2. It becomes a very high score, and this baby may require ventilator. 2 or 3 conditions which are very common, we'll see. You'll hear this word again and again, TTN. So it's very common, very mild condition. They'll only have tachypnea. Baby will be breathing very fast. Why? Because the fluid from the lungs does not come out during delivery. So during a normal delivery, it may be squeezed out, but during a cesarean, it does not get cleared. So it will remain for about 24 hours, causing mild distress. If you are able to take an X-ray, you will see there is little bit of haziness in the X-ray. So that treatment is very simple. A prognosis is excellent. The other one is RDS. All of you who have worked in the neonatal nursery will know this condition, and you know that there is a spectrum. You have a mild RDS, severe RDS. So this is predominantly occurring in preterm babies. There is no surfactant in the lungs. Surfactant is necessary to keep the lungs open. Otherwise, every time the baby takes a breath, lungs will open. When he expires, the lung also will collapse. So every time he takes a breath, he has to open the lung, close it, open the lung, close it. So he have very big problem keeping the lungs patent. But if you have surfactant, the lungs are kept open. Okay, so this surfactant deficiency is a very big problem in preterm, and the more and more extreme preterm they are, the more and more severe will be their distress. Okay, so this baby, that's why they say start on CPAP in the labor ward, start on surfactant in the labor ward, so that the transition is very smooth for the baby. He doesn't have to tire out his lungs. So what you will see in the X-ray in an RDS, you'll have ground glass appearance. Why? There is no air which has entered the lungs. Whole thing will be wiped out. Okay, to see a picture like that, you should be able to diagnose RDS, start on therapy very, very early, and save the baby. Pneumothorax, you know, it can occur spontaneously, especially in MSL, PPHN and all that, or it can occur during some procedure that we do. How do we know that there is a pneumothorax? That part of the lung, that part of the chest may be inflated, and then you will have decreased breath sounds. If you take an X-ray, that part of it will be very dark. Previous X-ray, what we said in surfactant deficiency, white out because there is no air. Here there is too much of air, so it will be black. Okay, then with the cold light, we know that when transillumination, if you see, the whole chest will be looking as it is lit up. Okay, so what should we do immediately? Put in a needle, drain it, and then the child will need a chest tube drainage. Pneumonia, very commonly we see in our country, 50% of the respiratory distress because of pneumonia. And preterm can get preterm. When do we see pneumonia? Usually maybe after ventilation or part of sepsis and all that we'll see. Okay, or baby, because he cannot feed well, he can aspirate the feeds. So how will you find out that this baby is having pneumonia? The baby can have temperature instability, hypothermia, tachypnea, respiratory distress, cyanosis. Sometimes these preterm babies, when you're taking them out of ventilator, after a few hours or one day later, he may develop apneic spells. At that time, you should think it is a ventilator-associated pneumonia. If you're going to give appropriate antibiotics, the outcome is very good. Whereas congenital pneumonia, we have to suspect when a term baby is born through a foul smelling, like a prolonged rupture of membrane, so mother is having fever, or it's a difficult delivery, or you have done multiple vaginal examinations, then you have to have the doubt about congenital pneumonia. Soon after birth, the baby will have respiratory distress. Okay, so we'll have to think in terms of congenital pneumonia. So these kind of babies, put the baby in a thermoneutral environment. Don't give anything orally for some time. Only IV fluids. Give oxygen depending on the need for oxygen. Either HFNC or ventilator. You will need antibiotics. I'm not giving you the schedule. Whatever you're using in your nursery, that you should start with that. MAS, this is the baby who was born through meconium stained liquor. Because of the asphyxia, all his reflexes will be lost. Normally, when something touches the throat, the baby will cough, will be able to vomit it out or spit it out. But when the baby is asphyxiated, he loses all his reflexes. Everything is open. So whatever he swallows goes inside. So that will go block the air passage, block the lungs, and it will usually be a big baby or a small for date IUGR baby. So when you see the baby, he will have meconium staining of the nails, cord and all that. These babies will come out fully stained with meconium. They'll have respiratory distress soon after birth. These babies will definitely require ventilation, higher modes of ventilation like high frequency or even INO the baby will need. So PPHN is a sequelae. Because of your MAS, the child can go in for persistent pulmonary hypertension. So what is the meaning of that? Here, normally after the baby is born, the pressure in the pulmonary vessels will come down, and then the blood will start go not it before it was going from right to left, that will change. But what happens is either in MAS or sepsis, this does not occur. The pressure is very high, so the baby will continue to be having a right to left shunt, resulting in cyanosis. So we have to dilate the pulmonary vessels. How do we dilate the pulmonary vessels? Either by giving more and more oxygen through a ventilator, or we can give high frequency ventilation, or we can give inhaled nitric oxide. Those of you who have INO therapy in your hospital, you will know that if you give inhaled nitric oxide, the pulmonary vessels alone will dilate, so the baby's cyanosis will improve, oxygenation will improve, and the baby will become better. So, okay, so much of problem is there, isn't it? By the time a baby comes out of ventilator, is there any way we can prevent respiratory distress? What is known and established is antenatal steroids. For RDS, it is proven with the antenatal steroids, you can reduce RDS, you can save the baby. Other than that, other measures which will help will be asepsis, either in the labor ward or theatre or NICU. As Lakshmi was saying, you maintain thorough asepsis, hand washing, gloving, mandatory. Suction lines should be clean, should not you should not give infection to the baby in addition to what the baby is having. Hand washing, strict. You follow all this, you can reduce the incidence of ventilator associated pneumonia, sepsis and all in the NICU. Then, what are antenatal steroids? We all know it's a very simple, effective way to prevent RDS and save the life of the baby. So between 24 and 34 weeks gestation, babies, when the fetus is between 24 and 34 weeks, the mother should get steroids. And how long will the effect last? It will last for 7 days. It will start about 24 hours later and last for 7 days. Okay. So injection dexamethasone 12 milligrams IM every 24 hours for 2 doses, or dexamethasone. Betamethasone is 12 milligrams every 24 hours for 2 doses. Dexamethasone is 6 milligrams every 12 hours, 4 doses. Okay, so total dose will be 24 milligrams. Either dexa in 4 doses or beta in 2 doses. So now we have come to the end of the thing. Whatever the cause of respiratory distress is, the principles are the same. Most important is supportive therapy. So keep the baby in a thermoneutral environment, monitor the baby. That is more important than all your sophisticated equipment. Monitor the baby. Whenever the baby is having a worsening of the down score, you know that this baby is becoming worse, is deteriorating. Continue the baby on adequate IV fluids. If blood pressure is dropping or blood sugar is dropping, monitor and maintain that. Oxygen therapy, ventilatory support, whether it is CPAP or mechanical ventilation, it should be given at the appropriate time. If you're going to delay, then there is no point in giving the treatment at all. So with this, I end the talk, and most of my slides have been from NNF teaching aids, where I wanted it to be simple and also just like an overview. So I thank the part of the organization. I'm also part of it, but I thank Lakshmi for giving me this opportunity to reach out to the nurses. And if there are 1 or 2 questions, or if it is permitted now, I can answer. Thank you.
Thank you, ma'am. You have explained clearly about the RDS and the signs and symptoms, and what are the scores to rule out the term and preterm babies, and the X-ray findings. I think it's very useful, ma'am. And I welcome the third speaker. If any question, anybody have any question, you can ask very well.
Okay.
Yes, ma'am.
No questions, I think, Panyamal. It's a good thing. Maybe they've all understood everything. Okay. Thank you. You continue with the sessions. I'll just join you. Okay.
Okay, ma'am. Thank you. So I would like to invite Ms. Kamala Rissi, the third speaker of this scientific session. She is a nurse educator currently working at Dr. Mehta's hospital. She completed her BSc nursing in 2012 She's with 7.5 years of experience in neonatal intensive care unit. She also completed her NNF fellowship in neonatology in 2013. Now I welcome Tamilarisi to present talk about the invasive ventilation. Welcome, Tamilarisi.
Can you unmute? No sound is there.
Tamilarisi ma'am, have you connected from two devices? I think that's in the echoing. ஏதோ ஒரு device ல connect பண்ணுங்களே. Sorry for the inconvenience.
சந்தியா முடிஞ்சிருச்சா முடிஞ்சிருச்சு பாருங்க
Good afternoon to all. Sorry for the inconvenience. Till now, we are discussing about invasive respiratory supportive care. Now, we are moving on non-invasive respiratory supportive care. First of all, I would like to say thanks Dr. Lakshman and Sister Kanima sister for giving this opportunity for me.
Can't hear you, sister.
Sister, slides மட்டும்தான் மூவ் ஆகுது, நீங்க பேசுறது கேட்கல.
Yeah, sorry for the inconvenience. First, we will see about heated humidified high flow nasal cannula. The non-invasive ventilation is a form of respiratory assistance that provides a greater level of respiratory supportive care than those of CPAP and may prevent the intubation and larger suction of neonates. The most common used technique for non-invasive ventilator modes are heated humidified high flow nasal cannula and CPAP and oxygen hood, and then nasal cannula. And then HFNC, the main goal is to optimize spontaneous breathing through the reduction of dead space and the creation of positive pressure to the airways. And what are the benefits? The first, it will help to reduce the ventilator-associated pneumonia and as well as lung injuries like atelectasis, and it will reduce the discomfort and mucosal damage, and it will reduce the secretions level, and it will help to reduce the ventilation rate and reintubation rate. Next, you will see about the indication. What are the indications? First, mild and moderate respiratory distress syndrome, and second one, post-extubation supportive care. Third one, post-operative respiratory supportive care, and then chronic lung disease, baby receiving more than 20 days for oxygen support. We can give for heated humidified high flow nasal cannula in order to prevent pneumothorax, and then recurrent apnea or apnea prematurity. What are the contraindications? The upper airway abnormalities such as corneal atoxia, cleft lip, cleft palate, and tracheomalacia, we can't use for this kind of baby. And then ventilatory failure, if baby is having severe respiratory arrest, we can't use for heated humidified high flow nasal cannula. And then severe cardiovascular instability like hypotension or severe PPHN, and frequent apnea in despite caffeine usage. That means recurrent apnea. And then we will see about what are the advantages for the heated humidified eye-flow nasal cannula. It will help and decreases the work of breathing and decreases the body energy from that. And loss of less problem with the nasal irritation and septal damage. And then initial management of mild ODs we can use, and it will help to prevention of intubation and re-intubation. It will create patient, parent, family friendly, like we can use for KMC in this mode, non-invasive advantages for HFNC. Before applying the HFNC, as a nurse, we are the major role in this work. So we have to place the deodorant for in order to prevent skin irritation or skin injury and skin peeling and then septal damage. So we should apply for deodorant or Decadam. See, what are the nursing care of child with HFNC, heated humidified eye-flow nasal cannula? First, we should divide it like patient observation and circuit observation. In the patient observation, whenever we have to take handing over, we should focus either heart rate is normal within the limit and respiratory rate and respiratory effort and oxygen saturation is within limit. Then circuit side, we should observe for flow rate, oxygen concentration, patency of nasal cannula, and tubing connection and humidification like 37.5 degrees Celsius. We should check while handing over and taking over. It's a very important role. Then cleaning for heated humidified eye-flow nasal cannula, it can be considered when the patient clinically improving, the clinical condition improves, we can disconnect it or we can stop the eye-flow nasal cannula, like decreased work of breathing and decreased oxygen requirements and normalizing the newborn early warning scores, we can stop. The special consideration, if we are using for heated humidified nasal cannula, means we have to take some special responsibilities in circuit temperature. We should check each and everything, every shift and every second one, and skin integrity, and then accuracy of measurements like snugly fit the head bonnet, and then pressure, and then any leak present in the circuit and flow rate and cannula size and impedance we should check. What are the troubleshoot we will face? The heated circuit alarm will come in frequently. So that time we have to check either nasal secretion or either nasal blocks there or disconnection from the tubes. Next, we will see about non-invasive respiratory care in CPAP, continuous positive airway pressure. The introduction about the continuous positive airway pressure is a non-invasive ventilation strategy for newborns with infant respiratory distress syndrome. It is one of the methods by which continuous positive airway pressure is delivered to spontaneously breathing newborns to maintain a lung volume during expiration. The definition of the CPAP, the continuous positive airway is a modality of respiratory support in which increased pulmonary pressure is provided continuously in a spontaneously breathing unit. It is distinct from the intermittent positive pressure ventilation, in which inspiration is provided by the ventilator machine, while peak and expiratory pressure keeps the alveoli open at the end of the inspiration and expiration. What are the purposes for CPAP? It reduces the work of breathing and stabilizes the alveoli and to prevent aftertaxis during expiration and to increase the functional residual capacity, and it will help and improve the gas exchange and increases the survival rate. It will good prognosis rate also. And contraindications. What are the contraindications? The poor respiratory drive and severe cardiovascular instability like hypotension and severe PPH in babies, and then progressive respiratory failure and congenital malformation like coronal ataxia, congenital diaphragmatic hernia, and tracheoesophageal fistula cleft palate. Next, we will see on about advantages of continuous airway positive pressure ventilation. It's a very simple device. It is easy to application. It will reduce the mouth leak, provide pressure relief, and then decreases need of surfactant and mechanical ventilation. What are the disadvantages for CPAP? It's difficult to obtain good fit because we are choosing the wrong size. For example, 1 kg, less than 1 kg, we have to select for 0 size. More than 1 kg, we have to select for 0 size. And then more than 1.5, we have to select for 1. And then more than 2, we have to select for 2 size. If you are select the appropriate size for the newborn babies, it's very difficult to fit and needs to frequent oral suction, and then difficult to apply in very small baby. And if baby is not comfortable with the CPAP mode, baby is continuously crying, that time we can the pressure will be lost. So the very highly chances trauma and nasal septum will damage because of improper handling and improper care for the newborn baby because choosing of the eye bone, the head bone side. Next, points to emphasis while babies on CPAP, the monitoring during CPAP. We have to divide two We have to divide it in that our monitoring for serial monitoring and continuous monitoring. In the serial monitoring, we check respiratory rate, grunting and retractions and air entry, and then temperature and heart rate, pulse rate. If continuous monitoring, we should check for urine output, capillary refill time and blood pressure and chest expansion. So while baby on CPAP, we should check this all the things present or not. And how will you assess if babies are receiving perfect CPAP and adequacy of CPAP? The baby is comfortable and absence of retraction or grunting and absence of cyanosis and reduction of FiO2 requirement and capillary refill time less than 3 seconds and oxygen saturation maintained within normal limits like more than 95 and then ABV is maintained the normal limits and then chest X-ray shows good lung volume. It's more than 4 to 6 and then the size of hands and palms. The CPAP size. If less than 1 kg, we can choose for 0, 0. In then more than 1 kg, we have to choose for 0. And then 1.5 to 2 kg, we have to select for 1 size. And then more than 2 kg, we have to select for 2 size. Next, we will see about the procedure of this CPAP. First, we should check if we are going to use CPAP means we should check for temperature, that is humidity temperature. The warm and humidity for the gases 34 to 37 degrees Celsius. Use appropriate size prong and size of the cap and cannula is designed on the weight of the baby. Connect cannula to the circuit and then machine or ventilator. If the ventilator is used, we can switch on the ventilator mode, so switch on the CPAP mode and keep gas flow at which continuous bubble present. We should separate the head of the baby by using the suitable padding and ensure that there is no undue pressure, there is no leak on the soft tissue, and then pass cotton tape through the holes in the CPAP cannula and fix the cotton tape in the sticky end of the flask. The cotton cap with tie can secure the cannula with it. It means make it comfortable zone to the baby. Otherwise, baby won't comfortable with CPAP mode. And then adjust CPAP to desired level, usually 4 to 5 centimeter in water level. We should set and ensure that there is no blockage, there is no any leak from size. In periodic observation is must. Every 2 hours once we have to observe. Then only we have to prevent some side effects or complications. Suction the oral cavity if there are any secretion present, otherwise unnecessary suction, no need to done. In order to decompress the swallowed air, the pass orogastric catheter and keep the proximal end open because we are applying positive pressure ventilation. That is definitely baby have the belly syndrome. So if baby on CPAP, we should check either baby is in place of OG tube or not. Then we have to decompress the stomach. Look for blockage of the nose and gentle suction may be required. If secretions are present, then only have to suction. Otherwise, no need. If we are giving unnecessary suction, it will stimulate the vagus nerve, then baby will have the bradycardia and apnea. If any discoloration or any leak will present or any damage will present in the CPAP circuit or prong, we can change. Otherwise, no need to change. If necessary, we have to change. And we should maintain the good position in sleeping position using of shoulder roll. We can keep maintain the airway and then check air entry equally bilateral air entry present or not. And then observe closely for signs of shock. If baby is on CPAP, we have to give continuous positive pressure. That then chances for IVH and pneumothorax and acute blood loss. So we should check monitor every 2 hours once. And then observe for signs of pneumothorax. And then monitor the blood test. We have to maintain the within the limit. Change the circuit if any color changes in the circuit, like in any discoloration or any infected materials or more water condensation or leaks. We have to change circuit if necessary. And humidification is very, very important. It should be maintained at 37.5 degrees Celsius too. Insert the OG tube to prevent the belly syndrome. Then we will see about oxygen hood. An oxygen hood or egg box is used for babies who can breathe on their own, but still need some extra oxygen. A hood is plastic drum or box with warm, moist oxygen inside. The hood is placed over the baby's head. It's a thin, soft plastic tube called nasal cannula. May be used instead of oxygen hood. This tube has soft prongs that gently fit into the baby's nose. The oxygen flows through the tube. Thank you, thank you to all. Conclusion my topic: if babies are receiving HFNC or CPAP or oxygen wood or nasal cannula, we should check if the tube was perfectly connected, and then egg bonus is fixed for the baby. Humidification should be maintained for 37.5 degrees Celsius, and then orogastry to be in placement, and then position of the baby, and continuous monitoring in the pulse rate, respiration rate, heart rate, and everything we should monitor every 200 hours once. And whenever we are taking over and handing over, we should check whether the machine condition like connection of tube, and then a flow heated individual flow, and then water level and bubbling condition we have to check. Thank you, dear. Thank you, Lakshman. Thank you, Bali sister.
Thank you, Tamilarisi, for the brief session on CPAP and HFNC. And I'll introduce our next speaker of the day is Dr. Shubha Karthikeyan. She's completed DNB, FPP, and FRCP. And she completed MBBS in Chennai Medical College from 1989 to 1995. And ma'am did a diploma of National Board in Pediatrics in 2000 in KKCTH. Also completed her diploma in American Board in Pediatrics in USA from 2003 to 2006. And she's completed a clinical fellowship in Neonatal Perinatal Medicine, University of Calgary, Canada from 2006 to 2010. She obtained a Royal College certification in Pediatrics and Neonatology in Canada 2010. And ma'am also doing her hospital-based and community locums in neonatology and pediatrics. From 2010 to 2012, ma'am worked as a neonatologist in Canada. In Chennai also, ma'am worked in various hospitals like Mehta Hospital and Motherhood. And she's a life member of NNF and AAP, certified as NRP instructor. Currently, ma'am is working in Madras Medical Mission, Chennai, senior consultant neonatologist. Ma'am is going to deliver a speech about surfactant replacement therapy. Welcome, ma'am.
Thank you.
Sorry for the inconvenience. Can you please just wait for 2 minutes? Dr. Shubha Karthikeyan will be joining. Sorry for the inconvenience. Dr. Shubha Karthikeyan will be joining shortly. She has some technical problem. So I like to invite next speaker, Dr. Akshit Timaya. She has completed her medical degree in 2006 at Mangalore, Muller Medical College. Also, she has completed her MT Microbiology from Kasturba Medical College, Mangalore from 2009 to 2012. She's playing a role of infection control chairperson at Dr. Mehta Multi-Speciality Hospital. She's a life member of Indian Association of Medical Microbiologists. Ma'am has also done many paper and oral presentation. Currently, she is working as a consultant microbiologist, head of laboratory service at Dr. Mehta's Hospital. Ma'am is going to deliver a speech on ventilator-associated pneumonia. Welcome, ma'am.
Thank you, Palani sister, but you have to give me an access to share the screen. I hope I'm audible to everybody. We just heard Dr. Lakshmi speaking and also Dr. Rama speaking and telling us about what are the indications for ventilator and how the ventilator, what ET tube to be selected and what is the indication for putting babies on mechanical ventilator. So now we know that all these babies who come on ventilator are extremely critical. Plus they are challenged with very low weight and low weight babies. So you can just imagine how much stress the parents are in, how much stress your neonatology is in, or any baby who's on ventilator. Over that, if you have to say that these babies who are on ventilator develops an infection from the hospital because they are on ventilator, it is not really nice, and it is adds to the pressure of maintaining these babies on ventilator. So ventilator associated pneumonia, if you see worldwide, or if you see in our hospital, is the second most common hospital acquired infection in the neonates after CLABSI. Okay, and why? What is this definition? Any ventilator associated pneumonia, if you say it is a ventilator associated pneumonia, what does it mean? It means any baby who has been on ventilator for 48 hours of life or more has developed pneumonia, okay, for a reason other than pneumonia where they've come and gotten admitted. But if you see in the previous indications, you know, there's all these babies who have come and gotten admitted have some form of lung inefficiency, right? So these babies, first of all, one is lung inefficiency. Second thing is they have inadequate immune response in because the newborn's immune response is not like adults. It takes time to mature, and over 6 months it matures. Okay, so when they are newborn, it is immature, so they are more and more vulnerable for any form of infection, right? Okay, it's stuck and I can't move the slides. Okay, right. So next one is, where do these babies get infection? One is called endogenous. Okay, endogenous means the baby gets infection from its own bacterial flora which is there in the mouth. These are called endogenous. Second, it can be due to reflux, that is from the gastric aspirate. Okay, it can be, there can be a gastric aspirate which the baby will aspire, it gets infected. Third one, the most important one, and which can be prevented, is from the environment, either from the equipments which are used for the baby or from the hands of the caretaker. So when we know this, okay, next is, what are the pathogens? So this is the pathogen pattern which we had last year. We had most common cause is Pseudomonas. Why Pseudomonas is a hospital, like when you get an infection with Pseudomonas, we say it is a hospital acquired infection, because normally Pseudomonas is not in our system. It's generally got from the environment. Klebsiella pneumonia is a second. You can have, because it is a hospital acquired infection, we have seen numerous Burkholderia species causing infection. That is also because of water can be the source. Staph aureus, which is a skin flora which can cause infection, which can, because the immunity is so low, they can cause infection in this immunocompromised baby or immunochallenged baby. Okay, when it comes to WAP, right? So WAP in neonates, why have I put so many question marks? Because it is not properly defined. When we have babies in neonatology, what happens is babies are very low weight or low weight babies. So the criteria for WAP has to change when it comes to neonates. But we don't have a CDC criteria which defines what is a WAP categorization for neonates, nor any of the other defined criteria, because it is very challenging, because these babies are already in respiratory distress. How will you recognize that the baby has got infected with something else and got a secondary, caused a hospital acquired infection, right? So it is very challenging to diagnose a WAP in neonates. As such, there is no definition. The CDC has given a definition which is less than 1 year of age. Okay, so WAP can be suspected if there is an instability in temperature. That means not only a rise in temperature, but also if there is a hypothermia, that can also suggest there is a kind of infection. And increased requirement of respiratory support. Okay, clinical deterioration, that is increase in leukocyte count or leukopenia. We also see a very common picture, that is the platelet level decreases in these children. Okay, then if you have a radiological changes which is compatible with pneumonia, abnormal laboratory parameters, increase in CRP, increase in procalcitonin. Okay, then tracheal secretions are very difficult to monitor, but if you're monitoring tracheal secretion, yes, if there is any signs of changes in the tracheal secretion, all these things can be a sign of the baby is going to ventilator associated pneumonia. Other than that, it can be a microbiological confirmation that there is some kind of growth in the secretions what you have sent, which can collaborate with your diagnosis of WAP. But as such, to conclude it has pneumonia, we do not need a microbiological confirmation. All right. So coming to preventive bundles, we know that as an adult, there are so many things which has been described in adults which does not apply to the baby. So in adults, we say they should be at 45-degree angle, they should be given prophylaxis. So all those things does not apply to WAP, right? 1 minute. Kiran, can you just close the door? Yeah, sorry for that. So one of the most important things is hand hygiene. Hand hygiene is extremely important because they are very low weight babies. Our hands are the healthcare people's hand, whether it's the doctors or your nurses. Their hands are extremely important because we are handling it, and we are the people who will be transferring the infection after we doing a suctioning or giving care to the baby to the ventilator. If we do not time this, that is, suctioning should be a separate sterile event and giving care to the baby should be the separate sterile event, right? So if you're not careful about it, and if you don't have one-to-one nurse for maintaining these babies who are on ventilator, usually they get infected because of cross contamination. So it is very important to do a hand hygiene. And when you're doing a hand hygiene for a baby, it should be with alcohol. It should not have chlorhexidine with it, which is not recommended. Second thing, other than finding using appropriate ET tubes or ET secretions when you're handling these babies, it's also important to remember the breathing circuit condensate, right? We already talked about, Dr. Lakshmi spoke about the condensate because it has to moisten the air which goes in. It's very, very important. So when we use a humidifier to do this, it's important that the water what we use and the condensate water is used has to be sterile. So this condensate of the tubings can also get infected and cause infection to the children. So it's important that whenever you're using these respiratory equipments, either you have to sterilize a reusable equipment. If you're not using a use and throw, that is single use respiratory equipments like ambu bag, you have two varieties. One, you have a single use, one you have reusable. If you're using reusable, it has to be sterilized before you use it to the next baby. Okay. Sterile water, important. Sterile water to be used in the humidifier. Sterile water, once you open it, it is non-sterile. Okay, so you have to be very careful how you open it. You have to use that small pouches of sterile water which comes in, right? Not bring the big can of sterile water, open it and use it for one day. It is not sterile at all. It can get contaminated. Then periodic drainage of condensate of the breathing circuit. Very, very important how you clean it. Once you clean it, you have to keep it dry till the other baby comes. And if you find that that is the one which is causing infection, you might want to sterilize by ETO. Very, very important. You have to be very careful while doing this for your babies. Then it's very important to do a timed mouth care, okay, for the ET tube, because what tubes you use is uncuffed tubes. So what happens, there's a risk of aspiration because of the tube. So whenever it is, other than what Dr. Lakshmi has said, other than the first few hours of life where it is not required, but a timed mouth care is extremely important to maintain the to remove the secretion and maintain this free breathing air circuit for the baby. So these are very, very important. And when you are doing a bundle care for a child or a neonate, it is very different. So it has to be customized for a neonate. You can't use a CDC criteria, or you can't use because there is no criteria as such. Even if you go to CDC website, it's for pediatrics. For the PICU babies, it is there. It is not there for neonates. So you have to customize for your center and make appropriate WAP bundle, which will be used by your nurses to as a bundle care. Okay, these are the preventive strategies. Just to summarize whatever I've spoken: so routine mouth care, appropriate hand cleansing, wear gloves while handling secretion. That means have sterile procedure when you're handling the babies, especially suctioning. We didn't think that only putting the ventilator or ET when you're inserting the ET, it is sterile. It is not important when you're doing suctioning. It is also very, very important when you're using suctioning. You use sterile gloves and do the procedure. Avoid intubation. Ask, Dr. Rama has also insisted on this, that is, every day you reassess and ask the doctor, is it required? Can we wean the baby off the ventilator? Very important question, which is the nurse's responsibility to ask the doctor every day, that can we wean this baby off mechanical ventilator? Shorten the duration of mechanical ventilator. Oral suctioning, we just spoke about. Then drain ventilator circuit considerant and elevate the head level. Not very appropriate for very small babies, because they are very, very small, so you can't elevate the bed level. But these are few of the preventive strategies which can be employed in your settings, in your neonatology, to prevent hospital acquired or ventilator acquired pneumonia or hospital acquired pneumonia. Thank you. If there is any questions, I would like to take it.
Thank you, Dr. Akshit. You have explained very well about the ventilator-associated pneumonia. Nowadays, many newborns are delivered prematurely. Definitely, they are going into ventilator care. So it will be very useful for our nurses how to take care of the ventilator patient and how to prevent ventilator-associated pneumonia. Dr. Shubha? Are you there, Dr. Shubha? Ma'am?
Sharmila, can you please mute yourself? Sharmila?
Can you please wait 2 seconds? I'll just ask Dr. Shubha Karthikeyan.
Any sister?
Yes, ma'am.
Hello.
Yes, ma'am. Shall I present,
Sister,
ma'am?
you do your talk, sister. I will do.
You just ask Dr. Shubha, ma'am. I'll present my topic.
Do it after.
Next speaker of the day is Sister Palni Ammal. She is going to present on target saturation. Welcome, Sister Palni Ammal.
Good evening to all. Today topic given to me is targeting SpO2 in neonates. Let us see about the introduction. So we all know that all the babies hello.
Sister Paraniamal, if you have multiple devices in the same log in or same area, then you will have a lot of echo.
Muted, sir, muted. Shall I start, sir?
Yes, please. You are good.
Okay, sir. Okay, nowadays we are receiving many of the preterm babies. Definitely, they are getting a supplemental oxygen. We all know that the oxygen is the one of the drug, as well as it is very toxic. So we cannot give more or less. If you give less, the baby will develop hypoxia, or if you give more, they will have a hyperoxia, because oxygen will create a problem for the baby, like retinopathy and bronchopulmonary dysplasia or cerebral palsy. We need to monitor continuously the SpO2 saturation, and also according to the saturation, we have to titrate oxygen therapy to the target levels. So oxygen saturation should be targeted within the range like 91 to 91%. So what is the target preductal SpO2 after birth? So soon after birth, in the delivery room or labor room or theater, we have to see the target level of the SpO2. So after birth, at the 1 minute of birth, if baby is having 60 to 65%, no need to worry, no need to give any additional supplemental oxygen. So the target saturation is mentioned according to the minute of the birth. So 1 minute, the baby will have 60 to 65. At the 2 minutes of birth, 65 to 70, 3 minutes, 70 to 75, 4 minutes, 75 to 80. You have to bother if at 10 minutes of birth, if a baby is having 60 saturation, so in that situation, you have to take aggressive action of administration of oxygen. So what are the oxygen saturation targets based on the term or preterm or chronic lung disease, or if baby is having more than 36 weeks. If preterm less than 32 weeks, the PO2 level, like in ABG, it has to be there 50 to 70. The saturation will be between 88 to 92%. In all rest of the preterm more than 32 weeks, whether term or post-term or CLT, the PO2 will be between the 60 to 80, and the target saturation range will be between 90 to 95%. So the nurse's responsibility. First thing, we have to assess the baby. The second one is alarm limits, monitoring, titrate of the oxygen, and disinfections. We'll see one by one. So in the assessment, what are the things we have to assess? After starting your first shift or second shift or night shift, first thing we have to check the general appearance of the patient. What are the things we can check in the general appearance? The activity of the baby and color of the baby, whether they are pink or cyanosed or ectric, and temperature of the baby. In coming to vital parameters, we have to check all the temperature, pulse, respiration, and everything, because if baby has hypothermia also, or if they are in cold stress means their extremities alone will have very cold. So if cold extremities there won't be any enough blood circulation, so you will not get in correct oxygen saturation. So these are all the things you have to monitor during the assessment. And level of protein. Baby is getting oxygen therapy, we have to check how much is the oxygen baby is getting, or which are all the methods of mode, in which mode baby is getting oxygen, whether oxygen or nasal cannula, or mechanical ventilation, invasive or invasive, non-invasive, everything we have to check. So if you are giving oxygen through nasal cannula, it not go beyond 2 liters. So that and all we have to check. Or in the oxygen humidifier, is there water is filled with humidifier chamber, because we cannot give dry air to the baby. So always you have to check these all the things. And selection placement of probe. So we have a disposable and reusable probes are there. So which type of probe are you using, and where you have to fix it, whether it is in the palm of the hand or in the feet. That and all you have to check. These are all the things we have to check in the assessment. Then coming to monitoring, we have to monitor in 3 methods. The first one is oxygen analyzer. The second one is transcutaneous wet gas monitoring, and finally pulse oximeter. So oxygen analyzer, I think everybody knows. It is a handheld portable equipment. And it should be first, before checking the oxygen FiO2 in the oxyboard, before that we have to calibrate the oxygen analyzer in the room air. So it has to show 21%. Then only we have to keep it in the oxygen. If baby is getting oxygen through oxyboard, you can measure how much percentage baby is getting and how much is the saturation. Based on that, we can titrate the oxygen level. So in case non-availability, if you don't have oxygen analyzer, so this is the flow chart to titrate the oxygen or to set the oxygen rate. So flow rate and the oxygen rate. If you are keeping 1 liter of oxygen and 1 liter of flow rate, for example, the baby will get 59.5% of FiO2. So this is a simple calculation we can fix in the level 3 or the baby carry area. So if you don't have any oxygen analyzer, we can use this chart and keep the oxygen saturation level at the target level. That is about the oxygen analyzer. Then transcutaneous blood gas monitor, it is invasive. It's very rarely we are monitoring. If baby is very critical in that situation, we can use this transcutaneous blood gas monitoring. That is arterial blood gas monitoring. So this is invasive and also it will create some infections and also cost effective. So finally, we will decide this one blood gas monitoring. In order in this monitoring only, we can able to find out whether baby is having hyperoxia or not. Then third monitoring is pulse oximetry. This is a pulse oximeter. So we can use, we can monitor through pulse oximeter or cardiac monitor. But only receiving oxygen therapy babies can have only this pulse oximeter. So these two types of probes are there. One is disposable, one is reusable. So anyone, which one is available in your institution that you can use. So it's a primary tool for non-invasive oxygen monitoring. So it's appropriate for continuous and prolonged monitoring. So probe selection and placement. So we can select a disposable or reusable. And placement is, as I already informed about the placement, in the form of the hand of the baby or in the. So it has to be rotated every second hourly or fourth hourly in all babies, because if it is there for a long time, it will compress the site of the probe. So there won't be any blood circulation. So you won't get correct saturation. So we need to, whenever you handle at least maximum to second hourly to fourth hourly, you have to change the probe site and check, because it will create burning sensation or any skin peeling will be there. So we have to change the probe site every second hour. So should all babies on oxygen be continuously monitored for oxygen saturation? Means definitely yes. All unstable patients, definitely we have to check the FiO2 requirements. And for stable neonates, we can check spot check like once in a shift. And the continuous monitoring is the best option. So in order to avoid oxygen toxicity. And also we can ensure whether adequate oxygen delivery is there for the tissues. Then alarm limits is very, very important. So we have to set in the beginning of each shift, we have to set the lower limit and the upper limit. Then only we can able to identify the sick neonate, whether the baby is having any problem or not. So lower limit up to 89, we can set upper limit 95. So it should be set to appropriate. We have adult mode and neonatal mode, many of the monitors. So we have to set the neonatal mode. And the respiratory readings are the range of 85 to 89, and a reading of 89 may reflect true arterial saturation as low as less than 80%. So we have we use monitor pre-ductal and the post-ductal. So there is difference about 10% difference between pre-ductal and post-ductal. That also all nurses working in NICU, they should know about the pre-ductal. So pre-ductal we will connect only the right hand is the pre-ductal. The rest of the left hand and both lower extremities is called post-ductal. So that the differentiates everybody must know. It's not more than 10 or 20. So alarm limits should be checked at each of the nursing shift. And also the waves we have to calculate. So the waves, if patient is having good saturation and the heart rate, the waves will be good. So if you can see in the monitor, the waves, this is not the good one, because if baby is having any desaturation or bradycardia, that time you can note this waves. So this, and also you have to train about the staff about the waves, and this is like asystole also will be there. So in that situation, you have to monitor continuously. If it is shows a straight line, you have to put it off and again you put on the monitor. In some monitor, the saturation will be 100% and the heart rate is 140, but the waves won't be there because it will get off. In some monitor, it will show. So you have to check monitors all the time. Whenever you handle the baby, whenever you go inside the patient's room, you have to check the monitors about the waves and heart rate and saturations. So coming to oxygen titration. So all preterm neonates will have fleeting desaturations, but sometimes it will self-correct without doing anything. It will come down, again it will go up to the normal. So but we have to check regularly. So we can't neglect that one. And also we have to assess the patient oxygen requirement clinically as well as through pulse oximeter. Then if patient is having severe or prolonged desaturations, so as I told in the previous slide, they will have frequently desaturation, then they will it will come up to the normal saturation. But if you neglect to monitor that one, the patient will have prolonged desaturation. That time you have to take immediate emergency treatment, and you have to assess for the baby if there is any severity for the baby, or you have to respond immediately. If patient is having desaturation prolonged, you have to respond immediately and get help from anybody and check whether the airway is patently and baby is breathing or not, and we have to start CPR immediately. And this, if baby is having desaturation, mainly the preterm babies, the common problem is apnea. So primary apnea is there, secondary apnea is there. So in primary apnea, with gentle stimulation, the baby will breathe spontaneously, and the color becomes pink and they will have good saturation. But if they are not responding to the stimulation, definitely you have to suspect that the baby is in secondary apnea. So in secondary apnea, the baby will have desaturation, bradycardia, and fully sinus. So in that situation, you have to take immediate corrective actions and document everything, what are the things happen during the secondary apnea. There are some points to keep in mind while monitoring the saturations. The best site for performing is already we have mentioned the points, everything in the previous slide. That one we are summarizing. So the best sites for performing pulse oximeter on infants is around the palm or on the foot. So when placing the sensor on the infant, there should not be any gap between the sensor and the skin. And the sides of the probe should be directly opposite to each other. And assure that the skin is clean and dry before placing the probe. And sometimes if baby moves also, it will differ the saturation, or some babies will have jitterness. So or crying, during crying, jitterness or movement, definitely it will affect the saturation, but we have to watch and ensure that the patient is calm. When the baby is calm and warm, during that time, if baby is having desaturation or bradycardia, that time you need to worry. If movement is there or shivering is there or crying, that time we cannot judge whether baby is having desaturation or not. And the infant requires pulse oximeter for an extended amount of time. Immediately, in that situation, you have to assess the site of the probe site, and you have to change the probe site every second hourly or fourth hourly, because there will be irritation and burning sensations. Next. என்னோட slide. Sorry for the inconvenience. So never attempt to obtain a pulsometer probe on the reading on the same extremity. If you are connecting the BP cable in hand or foot, you are not supposed to check the pulse oximeter on the same hand or foot because it will not give correct saturations. So again the same point is coming. So that should not be gap between the sensor skin, and it should be directly opposite to each other. The skin should be clean and dry before placing. So how do you disinfect? If you are reusing only, you have to clean the probe. If you are disposing it, no need. So clean with alcohol swab, and you can use it for another baby in order to prevent cross infections. In coming to special considerations, example bronchiolitis and cyanotic heart disease, you cannot expect the target ranges. So in bronchiolitis, the rate of equal greater than 90% with supplement of oxygen is more than enough. And congenital heart disease, it's about 75 to 85% is typically recommended for neonates. So thank you very much for listening. Dr. Shubha, are you there?
Yes. Am I audible?
Yes, ma'am.
Okay, let me try to screen share now. This
Okay,
computer virtual thing is kind of. Can you see my screen now?
Yes, ma'am.
Okay, let me go ahead then. Start.
Yes, ma'am, you can start, ma'am. I already introduced you.
Oh, yeah, lot of introduction. Thank you very much, sister.
Okay, ma'am.
Sorry for all the computer problems. It suddenly started updating itself when I started to talk. Okay, my topic here is surfactant replacement therapy, the role of nurses here. So all of you who are all neonatal nurses are very, very familiar about surfactant administration. It has been done in your unit so many times, and you would have seen all these brands on the screen, NeoSurf, Servanta, all of them being used. I'm just going to give you an overview of what the surfactant is actually, which you're giving to all these babies, and how you can give it in a sterile way to the babies, and what could be the problems by giving this surfactant. Okay, first of all, an overview. So what is surfactant? It's a mixture of phospholipids and proteins. That's as simple as it. And it's normally present in newborn lungs who are born at term. And the amount is totally dependent on the gestational age. So a preterm will have less surfactant compared to a term baby. When do we give the surfactant? Exogenously. Normally the preterms, the babies have it in the lung, but when do we give it? To them as a treatment. These will be basically, we see a common condition is preterm babies with RDS or hyaline membrane disease. You would have heard of all of this. What does it actually do is it decreases the prolonged need for ventilator support, pneumothorax, death, mortality. But in the longer duration of studies, they found out that by giving this medicine as a surfactant as a medicine does not cause any increased neurodevelopmental problems like development of the brain. So this is the lung development of a baby. And as you see in this chart, oh my God, it's so sensitive. The final stages, which is the saccular and alveolar stage, this is when the surfactant is starting to be produced. So these are the earlier stages where we see the big bronchi and their branches are all formed. But where the terminal bronchioles and the alveoli, this is the final where the surfactant is, that is definitely produced from the 25th week till term, and you see it is increasing as you go to term. So what does the surfactant do? So air has to enter the terminal bronchioles to the alveoli, and from the alveoli, whatever oxygen is there has to go to the capillaries. That's how oxygen enters the capillary, which is the blood, and goes to the different parts of the body. But if this alveoli is collapsed, the air is not able to enter properly and the oxygen does not enter the capillary. So you have a lot of deoxygenated blood, which is not having enough oxygen. So this surfactant which we give to these babies lowers what is called the surface tension, which I will talk about in the next slide, and keeps the alveoli nice and open so that all the air with the oxygen can enter the alveoli and exchange, give the oxygen to the capillaries here, which carries blood, and this can go and take good oxygenated blood to the baby's different parts of the body. Okay. So the same thing explained here. See, this is a collapsed alveoli with all the capillaries around it. Air is not able to enter, so oxygen is not getting into the alveoli, so there is no exchange happening here. So the blood is deoxygenated and does not have. So insufficient surfactant, collapsed alveoli, inadequate oxygen exchange. Here surfactant is there or it is even given exogenously. The alveoli are nice and open like a balloon and expanded. So oxygen, air enters into it. So oxygen goes into the capillaries and carbon dioxide comes out of the capillaries. So this surfactant is a lining which is present around the alveoli like this. So if you see this slide, this is the mechanism of action of the surfactant. So what does it do normally? This is, let's imagine this is the alveoli and there is water layer around the alveoli. This water molecule produces a tension which tends to collapse the alveoli. That's the surface tension which tends to collapse this alveoli. Collapsing means like a balloon which is blowing off air out and makes it, oh my God, where is the cursor? And makes it small. But what does this surfactant do is, the surfactant has an amphipathic structure. It has a head and a tail. The head is hydrophilic. Hydrophilic meaning water loving. It goes and sits along with the water molecule here, which is present in the water molecule. It goes sits along with the water molecule, which is called the air-water interface. And the hydrophobic tail is hanging in the alveolar space. So this surfactant which sits here as a layer in the air-water interface decreases the surface tension which is caused by the water molecule and keeps the alveoli nice and distended. So what is the composition which makes this surfactant work like how it's working? So what does it basically contain? So the main components which you should know are these two, the dipalmitidyl phosphatidylcholine and the protein component. This is the phospholipid I was talking about, and this is the protein I was talking about. There are other phospholipids which are also present, which are significant in certain ways because they can be detected antenatally, the sphingomyelin, things like that. And some phospholipids can be detected in the amniotic fluid in diabetic babies. But the main thing you should know are DPPC and the proteins. The proteins, there are 4 proteins, A, B, C, and D. But A and D are hydrophilic, just like water-loving ones, and they are responsible for regulation and recycling. All that surfactant we give, which is recycled to produce more surfactant and for defense mechanism. And hydrophobic, which is B and C proteins, are responsible for spreading the surfactant uniformly around the alveolar lining. Now history. So who are the great minds who found out a substance like this and are helping, which is helping all our preterm babies survive? So initially it was started off with the surface tension issue only. So surface tension as a force counteracting the first breath. This is the most important evil they thought. Why is it counteracting the first breath and not helping the babies breathe properly? This resistance to aeration due to surface tension. All this was debated by initially Nergard and lots of Canadians, Englishmen, and Americans. And finally, Dr. Fujiwara, our Japanese person, who was working in California for a long time, came to Japan after finding the surfactant and used it on 10 infants. And this paper was published in 1980s in the Lancet, which showed that once you give surfactant, the PO2, which is the indicator of the oxygenation of the blood, is increasing dramatically in preterm babies once you give surfactant. So that was the first time it was used, and henceforth it was used regularly on preterm babies. Now we talk about RDS and RDS causing this surfactant deficiency. So surfactant deficiency per se, what are the symptoms it causes clinically and radiologically for the babies, which we term as RDS. So what does it happen? So these alveolar are collapsed in these babies when they are born. So what happens? They are trying to keep their alveoli open. So how do they keep their alveoli open? They make a noise called grunting. So all the neonatal nurses here would have heard what is called grunting. It's kind of a straining kind of noise a baby makes. Why does it make this? This is actually what the baby is trying to do is that the baby is trying to breathe through a closed glottis. Glottis is a space between our vocal cords. So the baby is trying to breathe out with a closed glottis. What happens at that case is you're trying to breathe out, but your opening to breathe out is closed. This increases the internal pressure, so keeps the alveoli open. So this grunting helps them keep the alveoli open in the absence of surfactant. And then they are tachypnic because they want to increase the minute ventilation. So they breathe fast, thinking by breathing fast, at least they can get a lot of air into their lungs for oxygenation. So these are all the mechanisms to increased PO2 or oxygenation in these babies. Grunting, they're tachypnic, nasal flaring, intercostal retractions, working really hard using all the accessory muscles of respiration to get more air into the lungs. But because of the lack of surfactant, they're not able to maintain saturation still. Now, if you take an X-ray, this is what you see. The air is not getting into the lungs, so it's all white out here. And the air which is going into the bronchi and going into a collapsed alveoli without air is the air bronchogram. So this is what we say as ground glass appearance with air bronchogram. Hello? Okay. Hello?
We can hear you, ma'am. Ma'am?
You can hear me? Hello?
Yes, yes ma'am.
Okay, fine. So in the absence of surfactant, what happens? To keep the alveoli open, we give high pressures to keep the alveoli open. So this high pressures on the alveoli, which is trying to collapse, is actually stretching the wall and distorting the wall of the cell of the alveoli and the cells in the alveoli. So this distortion and destruction of the alveolar wall leads to this hyaline membrane disease and hypoxemia, which finally can lead to chronic lung disease. Oh my God, what is happening? Okay. So now we are going to see where is this surfactant produced. So there are certain cells. So this is the alveoli. There are certain cells called type 2 cells in the alveolar wall epithelial lining, which produces a surfactant, which are aggregated as lamellar bodies. These lamellar bodies form what is called the tubular myelin, and then they form a layer on the alveolar lining here. This is the air-water interface, which I was mentioning in the previous slide. So this is where they're formed. Let's go as a magnification of the whole thing. This is the alveoli. This is where the alveolar surfactant is lining. This is where it is produced by the type 2 cells. Exocytosis comes in lines here. The used up surfactant, which has performed its function, is taken up back and recycled here, and part of it is taken by the alveolar macrophages. Types. So there are different types of surfactant, all of you will know, right? There are different types of surfactant from animal derived. So main thing is surfactant is animal derived. The different animals it's derived from is from the cows and the pigs, right? So they are called, they can be minced bovine, that is bovine lung is minced and used, bovine is cow, or it could be minced porcine, which is pig's lung, which is minced, or it could be lavage of the calf lung. So a calf is a cow's baby, right? The lung is lavaged, like a gastric lavage. They're lavaged, and that surfactant liquid is used for treating preterm babies. So each one, how they are different. They're different in the two main components which we discussed about in surfactant composition, the DPPC and the phosphatidylglycerol and the protein component. So The minced bovine lung component has only 25 milligrams per ml of phospholipid, but the porcine ones is 80 milligrams per ml of phospholipid. Because the phospholipid concentration is high and our dose for treating preterm babies for surfactant deficiency is 100 milligrams per kilogram to 200 milligrams per kilogram. Higher the phospholipid concentration, lower is the dose you give for the baby. Like if you're giving Cervanta in your unit, then you will be giving 4 ml per kilo of Cervanta. But if you're giving Neosurf, then you will be giving 3 ml per kilo. But if it's Curasurf, then it will be 2.5 ml per kilo because the phospholipid concentration is high in them. Okay. Then there are certain synthetic surfactant, which is not from any of the animals, synthetically prepared. The earlier ones did not show any promising results, but the newer ones, leucinactant, has the protein, because earlier they could not produce the protein component, which is very important for recycling and use. But now in the current synthetic ones, they have the protein component. So now this shows a lot of promising results with the synthetic surfactant itself, because even this animal derived surfactant have their own side effects, which can be overcome by using the synthetic one. Okay. Next, how do we give them? So we learned about what they are, what they're used for, and how they're prepared. Now we are going to give them. So there is something called prophylactic and rescue. What is prophylaxis? We all know. You give it before something comes. Rescue is after the disease comes, you're going to try to rescue the person from a severe illness. So earlier what we used to do is we used to do prophylactic surfactant. Prophylactic is baby is preterm, baby is just born, and we immediately give surfactant to it in the case room itself. But then there are a lot of studies that saying that initial stabilization with CPAP is pretty enough for these babies. And then they require intubation and they meet the criteria for RDS, which I told you about the clinical and the radiological criteria. Then you can treat them with rescue surfactant within the first 2 hours of life. This is a newer guideline. And I think all of the units says immediately don't have to rush and give surfactant now. You can stabilize them with CPAP if they're an older gestation. Young gestation, you cannot stabilize them with CPAP, then you have to intubate them. Then you put them on the ventilator and then see when they meet the criteria, still requiring a lot of oxygen and showing clinical evidence of RDS. You give surfactant in the first 2 hours of life. After some older preterm, sometimes they stabilize on CPAP but do not go down on their oxygen requirement. Then you have to do late rescue therapy. All of it has supposed to decrease BPD and death. Now the procedure. So this is very important for you people because all of you will be assisting in surfactant administration in your unit. And some of you might be doing it alone also. So all the equipments we need for surfactant, it's a very sterile procedure and we need definitely a cardiopulmonary monitor here. Which is very, very important because that tells us the status of the baby when giving surfactant. We need a neopuff or, if you have an anesthesia bag to give PEEP and PIP during the surfactant administration, a sterile gown, and you should be sterile, and all the sterile things which should be put on a sterile tray. So what we should do with surfactant administration is very important is cardiopulmonary equipment, surfactant, feeding tube, syringe and needle to draw the surfactant, sterile towels and drapes where we can put all the sterile things, tape measure, scissors. So why do we need the tape measure and the scissors and the feeding tube? So what we do normally is we have to cut the feeding tube to the length of the endotracheal tube, measure it and cut it with the sterile scissors so that the feeding tube can be inserted into the endotracheal tube and the surfactant can be instilled into the trachea. So prior to administration, you have to ensure correct endotracheal tube placement, suctioning prior because you're not, there's no use if you suction immediately after giving surfactant because all the surfactant from which you have administered has gone off. Very important. And then you have to warm the surfactant. So very important thing is artificial warming is not advised because the the substance gets degraded. So the vial should be kept out for some time so it come to room temperature. Then you have to give it. Some surfactants you can inspect for discoloration to see if the product is not good. And very important is documenting the dose in the chart, which is very, very important. How do you administer? First, you have to draw it, use an alcohol swab, wipe the surfactant, dry it up. A second helper can do it, and you in a sterile way draw the surfactant. The very important thing is the position of the baby. Earlier, we used to change positions, thinking that will gravitate the surfactant to different parts of the lungs. But now we don't do anything like that. Just a supine position with head in the midline is enough. You can disconnect. There are 2-3 ways of doing it, but the recommended way, we used to do it earlier in a second port, which I will show it to you in the next picture. So this is what they used to do earlier. We used to not disconnect the baby from the ventilator, not even use the anesthesia bag. The baby will be connected to the ventilator here. The second port, we used to put the feeding tube in through this, and we can use to deliver the surfactant, or directly they can plug in the syringe to the second port and give it to it. But now the evidence is and through this you can only do a slow infusion. So now the evidence is disconnect the baby from the ventilator, give a bolus dose of surfactant. So using a non-touch technique, administer 1 push of surfactant followed by 0.5 ml of air, and correctly charting the device, charting the medications in the chart, and document the time, date, and the response of the patient to the surfactant administration. Okay. So what is better? So now the new technique is bolus technique. If the child tolerates, if the child is desatting terribly and you can't do anything, then you have to abate the bolus. But it's better to give the whole dose into the baby's ET and then start bagging after that. So they say this liquid plug which is formed in the trachea is driven to the distal parts quickly and spreads very evenly in a uniform manner with the bolus technique compared to the slow infusion which we used through the second port. Okay. Ventilating strategies post surfactant. So normally all of us, I think, you bag with higher pressures post surfactant, and because of higher pressures, the rates are low. But the evidence says that a rate of 60 per minute is advised after administration, followed by till the surfactant gets cleared and the baby is fine. Then you can connect the baby to the normal ventilatory settings. So they get deposited on the airway wall and then transferred by gravity to the dependent parts, and it's a uniform distribution by doing this post surfactant administration. Very slow ventilator rate can lead to non-homogeneous surfactant distribution to certain parts, which can cause chronic lung disease changes later. And the very important is no suctioning 2 hours post. You should monitor vitals post surfactant administration. And very, very important is weaning the ventilatory parameters. This baby without surfactant was on high ventilatory parameters. Once the surfactant is given, the alveolus is going to open up like anything and fill up with air, and so the pressures which we're giving have to come down drastically, and oxygen is also should be weaned. Storage. So how do we store the surfactant? So normal 2 to 8 degrees refrigeration, should not be shaken. Always based on whatever the 2.5 ml per kilo or 5 ml per kilo, the appropriate vial by the manufacturer should be used. Excess should be discarded. And unopened, if you've taken a couple of vials extra, they can be refrigerated back within 24 hours. But we can't redo it multiple times. Only once if you've taken it out and you've stored it. Then the second time, if you kept it out for a long time, we can't restore it back into the refrigerator. So what are the techniques? So now we talked about single technique in which you, through the endotracheal intubated child, you give surfactant in a bolus dose. So there are different techniques which have come through the years. The Ensure technique. There is a non-invasive technique. I think Dr. Lakshmi was talking a little bit about it. Then there is laryngeal mask airway, LMA. I don't know whether you've heard about it, but it is used in certain centers. Then nebulizing surfactant, which is coming. A lot of studies are going on along with it. So let's talk about the Ensure. What is Ensure? You intubate the child, you give surfactant and extubate the child to CPAP. This is very, very good because it decreases the duration of ventilation. More ventilation, more injury to the lungs. So they can lead to chronic lung disease. So this technique can be used as much as possible by avoiding ventilation for most of our preterms. So this is how they do: intubate, surfactant administration, and then go back to CPAP. So this is what I was talking about, the feeding tube length. You measure according to the length of the endotracheal tube for administration of surfactant. Then minimally invasive surfactant administration is called MIST. Here you don't intubate the child at all. They receive surfactant via gastric tube placed in the trachea. So how do we do it? We just visualize the trachea like a normal endotracheal intubation. With a McGill's forceps, you introduce the feeding tube into the trachea and you administer the surfactant. There is another technique just like MIST, which is called LISA, which is less invasive surfactant therapy, in which you use a rigid vascular catheter. So you don't have to use a McGill's vascular catheter, and you can insert the vascular catheter and then deliver surfactant when the baby is on CPAP itself with no other added measures. Then laryngeal mask airway is another one which can be used for surfactant administration. Advantages. So why are we going to all these newer techniques? Because we don't have to sedate a baby, but not the West mostly they sedate a baby for intubation, but here we don't. And we can use it on a spontaneously breathing preterm infant, right? Who's on CPAP. Definitely minimizes airway injury and the long-term outcomes like chronic lung disease and death. Disadvantages is, as we put it in, lot of surfactant refluxes back into the tube. So a lot of surfactant is refluxed, and more surfactant loss is noticed in the case of LISA and MIST compared to regular endotracheal tube surfactant administration. Complications of surfactant administration. So all of surfactant goes and sits in the upper airway with the bolus therapy. So transient oxygen desaturation and bradycardia. Significant complications can be severe airway obstruction, just like what I mentioned above. Pneumothorax, because of unequal distribution, some gets hyperinflated, some gets less aerated. And pulmonary bleeds very, very rarely with surfactant as a complication. So this is what they're doing at the second port. Okay, they're bagging in one port and they're instilling surfactant in the other port. Okay. So what is the take-home messages which I think I have delivered in this speech is: what is surfactant, its mechanism of action, uses and composition, different types, animal-derived surfactant and synthetic surfactant, the sterile way of administering it to preterm neonates, different methods of administration, complications, and what you have to monitor before and after surfactant administration. Goodbye and stay safe. Can I take any questions?
Thank you, Dr. Shubha ma'am.
Thank you.
It was very explanatory about the functions of surfactant and how to administer and what are the complications and type sources, ma'am. It was an informative session. Thank you very much, ma'am.
Thank you.
Dr. Lakshmi, you will move on to Kahoot games, ma'am. Ma'am?
Yes.
Shall we move on to Kahoot games, ma'am?
Yeah. What should I do? I downloaded it.
Yes, ma'am. Kahoot, ma'am. You have to download the Kahoot app, ma'am. If you don't have Kahoot app now, you have to type in the kahoot.in, ma'am, the website. Kahoot.it.
அந்த பின் கேக்குதே.
Shall we will share, ma'am. What is the thing, ma'am?
Dear audience, let us play a quiz through Kahoot. If you have Kahoot app, enter the pin which we'll be sharing. If you don't have Kahoot app, kindly go to website and type Kahoot, Kahoot, Kahoot.it. It will show play Kahoot. Then enter the pin which we are going to give. Nine zero 1240. 908-1240. Delegates, our Kahoot pin is 9081240. Till now, 3 delegates have been joined. Tamilarasi, Palniyammal, and one more Lachu. Narmada has been joined. Our Kahoot pin is 908-1240. Let us wait for some time to start the quiz. Another person has joined, Revati. The Kahoot pin is 9081240. Kaushik, welcome Kaushik. Let us wait for some more time. Dear delegates, if you have Kahoot app, kindly join through app. If you don't have, go to website and type kahoot.it. KAHOOT.it. A pin is 908-1240. Now we have 6 delegates to play a quiz.
Sister, can you post the link and the pin on the chat box?
Lakshmi ma'am, can we start the quiz? We have only 6 delegates, ma'am.
Can you post the chat box, la pin? Can you put the pin in chat box?
Pin and the link, both on the chat box.
Lakshmi ma'am?
Yeah, I'm here.
Can we start the quiz?
Yeah, you just put the number once more, not pin number.
Pin number 9081240. Our Kahoot pin is 9081240. Okay, let us start the quiz.
Okay.
Signs and symptoms of respiratory distress syndrome. We have 30 seconds to answer. Two answer correctly. Second question. What is the maximum suction pressure used in newborn? 100 mm Hg, 90 mm Hg, 110 mm Hg, 60 mm Hg. What is the maximum suction pressure used in newborn? No one answered correctly. 3 of them answered correctly. 100 mm Hg. Let us see the scoreboard. Ravati is on top. She got 1757 points. Tamilarasi is in second place and Narmada is in third place. Next is functions of surfactant are stabilize the alveoli, reduce the surface tension, A and B, atelectasis. Functions of surfactant are. We have 10 more seconds to answer. Answer is A and B. 4 of them answered correctly. Even now, Revati is on top. Next question. What is dope? DOPE. What is dope? Expansion of dope.
எல்லாம் நான் கரெக்டா இருக்கிறேன். எனக்கு ஏன் முட்டை போடுறீங்க?
கரெக்டா போட்டுட்டீங்களா?
We have 8 more seconds to answer. Displacement, obstruction, pneumothorax, equipment failure. This is the right answer. 2 of them answered correctly. Now also Revati is on top and Tamilarasi is on second place. Narmada is on third place. Next question. Abbreviate insure. Insure. Invasive surfactant extubate. Immediate surfactant extubation. Intubate, surfactant, extubate. Initiative, surfactant, extubation. Abbreviate, insure. We have 10 more seconds. Time is up. All three answered correctly. Revati is on top. She got 4,207 points. Tamilarasi is in second place, 3,956 points. Next question, sixth question is preventive strategies of VAP as follows. Preventive strategies of VAP as follows. Head and elevation, 30-degree head and elevation, hand washing, suctioning, all of the above. Till now, 3 gave their answers. We have 5 more seconds. The time is up. Three of them answered correctly. Answer is all of the above. Now also Revati is on top. Let's go to next question. Complications of CPAP except complications of CPAP except pneumothorax, septal necrosis, feeding intolerance, Bellay syndrome. We have 15 more seconds to answer.
Pneumothorax.
5 more seconds. 5 of them answered. 4 of them answered correctly. Answer is feeding intolerance. Now Tamilarasi is in first place. She got 5,722. I think Dr. Lakshmi ma'am also have been joined. Revati is in second place. She got 4,943. Let us go to next question. What is normal pH? What is normal pH? What is normal pH in ABG? We have 15 more seconds. One more to be answered. I think 4 gave their answers. We have 2 more seconds. Time is up. All 4 gave correct answer. Is 7.35 to 7.45. Again, Tamilarasi is in first place. Next question of our quiz is, what is the CPAP humidification temperature? What is the CPAP humidification temperature? 36, 34, 37, 35.
36.
We have 10 more seconds. I think all 6 answered for this question. This 37 is the right answer. 3 gave right answer for this question. Let us see the scoreboard. Tamilarasi is in first place. Revati is in second place. Narpada is in third place. Palniammal in fourth place. And Lachu is in fifth place. Next question. Target saturation for term babies are?
92 to
Target
95.
saturation for term babies are?
89 to 92. Okay,
We have 10 more seconds. Right answer is 92 to 95%. 3 answered correctly. Lakshmi ma'am came to 4th place. Narmada is in 3rd place. Revati is in 2nd place. And Tamilarasi is in 1st place. Next question. What are all the complications of suctioning except? What are all the complications of suctioning except hypoxemia, bradycardia, atelectasis, hyperoxemia?
Hypoxemia.
We have 5 more seconds.
Atelectasis.
Hyperoxemia is the right answer because we asked what are all the complications of suctioning except. 2 of them gave a right answer. Lakshmi ma'am came to 3rd place, Revati is in 2nd place, and Tamilarasi is in 1st place. Next question, expand mist. Expand mist, M-I-S-T, mist.
Invasive suction therapy.
We got answer from 4 of the delegates. All 5 answered. We have 2 more seconds. The right answer is minimal invasive surfactant therapy. 4 of them answered rightly. Next question is, the following are true about NTL. The following are true about NTL. We have 15 more seconds. Five more seconds. 3, 2, 1. Time is up. The right answer is all of the above. 3 of them answered rightly. Same scoreboard. Next question is, what is the tool used to rule out respiratory distress syndrome in term babies? What is the tool used to rule out respiratory distress syndrome in term babies? We have 15 more seconds. Five more seconds. Yeah, the answer is down score. 3 of them answered correctly. Last question of the quiz is radiological appearance of RDS. Radiological appearance of RDS. Sorry for the spelling mistake. Second one is ground glass appearance. Typo error. We have 3 more seconds. Okay, the right answer is all of the above. 4 of them answered correctly. The final score is Dr. Lakshmi ma'am is in 3rd place. She got 7,660 points. Second place is Revati. She got 8,404 points. Sister Tamilarasi is in 1st place. She got 10,973 points. Congratulations to winners. Thank you.
Thank Thank you, Sister Ms. Tilakavati, for conducting the very interesting Kahoot game. Now we have come to the end of this program. Ma'am, can you quote the webinar, ma'am? Lakshmi, quote of 10.
Okay. First and foremost, thank you, Mr. Kaushik Ganguly, for being with us and taking your time and for your participation in the quiz also. Thank you so much for all your association with the NNF. I thank the nursing team led by Pioneer Sister and the entire nursing team of Dr. Mehta, Ms. Leena, Tilaka, Pioneer Sister and Tamilarasi for all their inputs and doing this program in a very energetic and exciting way. I also thank all the co-speakers, especially Dr. Rama Chandramohan, Dr. Shubha Karthikeyan, and Dr. Akshit Timaya for their wonderful lectures with a lot of good points for the nurses. I thank each and every one of the delegates for taking your time to log in and attend this webinar. I'm sure it will be of great benefit to you all in your nursing practice. Thank you one and all. The main idea of doing such webinars for nurses is to empower the nurses so that they raise their standard and come and stand on par with the doctors. And your standard of care will definitely be reflected on the standard of care of the neonate. That is the main aim of having such webinars. And this is the third webinar in a row we are doing. And we're going to have many more webinars every month on selected topics. And always, this is the first time I'm also playing the Kahoot quiz. And it was also very exciting. The first 5 questions I answered rightly, but the marks didn't come there. So I request all of you to participate next time with your downloaded Kahoot app in your mobile. Technology is advancing. We also have to run on par with the technology and participate in such things. Once again, from the bottom of my heart, thanks to UNICEF, thanks to ECOM Foundation, Subhashri for all the groundwork, thanks to the NNF, Dr. Rama Chandramohan for the support, thanks to Mehta Hospital for making this wonderful event put together, and thanks all the delegates for taking your time to be with us. Thank you, one and all.
Thank you, everyone. Thank you for making it a success.
Bye-bye.
Bye.
Thank you.